Hello, hello. Hello. Hello.
Hello.
A very good morning to one and all present here. We are truly honored.
Hello.
A very good morning to one and all present here. We are truly honored by the presence of our renowned speakers, respected Dean Sir, distinguished faculty members, and enthusiastic participants from various institutions.
On behalf of the organizing committee of this CME and workshop on diabetic neuropathy, autonomic function tests as key to early diagnosis, I, Ankita,
And I, Megha,
welcome you all. Today is a proud day for us. The Department of Physiology MTMC, under the tutelage of Mahe, is conducting this CME and workshop on autonomic function tests.
diabetes has become a household name for quite some time now. Many people amongst us must be diabetic. Did you know that according to the latest Diabetes Atlas 2025 reports, that around 11.1% or 1 in every 9 individual of the adult population aged 20 to 79 years suffers from diabetes. Furthermore, this statistic is expected to rise by 46% by 2050.
In the emerging era of diabetes mellitus, one critical aspect continues to be neglected, that is the autonomic dysfunction. The early diagnosis of autonomic dysfunction is of prime importance, as it affects the prognosis as well as the lifestyle of the patient. Hence, this CME aims at addressing this issue and sensitizes the medical fraternity about the common autonomic function test and a nerve conduction study.
To begin with, Dr. Harish Chandler Bandhu, Dean MTMC. Dr. Rajiva Dwivedi, Director, Academic Admin and Quality, MTMC. Dr. Ashok Jaryal, Professor, Department of Physiology, AIIMS, Delhi. Dr. Rajesh Kumar Thakur, Head, Department of Medicine, Tata Motors Hospital, Jamshedpur. Dr. Mitesh Sinha, Professor, Department of Physiology, Birsa Munda Government Medical College, Shahdol, MP. Dr. Shival Srivastav, Associate Professor, Department of Physiology, AIIMS, Jodhpur. Dr. Swikriti Behra, Organizing Chairperson of CME, Professor and Head, Department of Physiology, MTMC. Dr. Sindhu R, Organizing Secretary of CME, Professor, Department of Physiology. We also welcome Dr. Madhumita Sen, Unit of Medicine, AIIMS Institute of Malaysia, and she has already joined us online.
We now request the dignitaries to kindly proceed for the ceremonial lamp lighting.
शुभं करोति कल्याणं आरोग्यं धनसम्पदा 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं करोति कल्याणं आरोग्यं धनसम्पदा
Sakshi, Aisha, Ariba, and Tanu for giving a melodious start to the event. We now request our organizing secretary, Dr. Sindhu R., to share a few words on the CME and associated workshop.
Respected Dean, Dr. Harish Chandra Bandhu, Director, Dr. Rajiv Advivedi, Associate Deans, eminent speakers, distinguished delegates, esteemed faculty members of MTMC, and my dear students. I stand before you as the organizing secretary of the National CME on Diabetic Neuropathy, Autonomic Function Tests as key to early diagnosis, and seek your support and encouragement in making this academic event a great success. All academic gatherings can be fruitful and enjoyable if the topics are informative, interesting, and interactive. We have tried our best to incorporate a variety of scientific talks, each delivered by the experts in the respective area. The speakers have done extensive work and are well known in their areas of expertise. The idea of the CME was mooted a few months back when our team was brainstorming on ideas that cater to a wide spectrum of audience for clinicians, medical teachers, researchers, and learners. While the topic selected is clinically relevant, it aligns well with the CBME guidelines mandated by our NMC. The incidence of type 2 diabetes mellitus is growing leaps and bounds across the continents and constitutes a major non-communicable disease of our society, affecting the young population. Diabetic neuropathy and autonomic dysfunction, being one of the serious complications, demand early detection and treatment to prevent loss of protective sensation, cardiovascular, and other systemic abnormalities. Cases have been reported where the quality of life has suffered for several years because of postural hypotension, gastroparesis, bladder emptying abnormalities, hypoglycemia unawareness, etc. In several cases, these systemic changes have already set in at the time of diagnosis of diabetes mellitus. These can be attributed to lack of early detection, poor glycemic control, and not so effective treatment for diabetic neuropathy. Today's CME and workshop aim to address these shortcomings, at least to some extent. Our speakers will throw light on various aspects of diabetic neuropathy, autonomic function tests, early detection, and treatment. We are very delighted to share that we have received an overwhelming response with 35 delegates registered for workshop, 80 for offline CME, 340 plus for online CME, and still we had inflow today morning. The participants hail from various states across the country, along with a few international delegates. Owing to the enthusiastic response and the number exceeding our expectation, we had to close the registration for the workshop and offline CME ahead of time. I extend a warm and heartfelt welcome to our respected Dean, Dr. Harish Chandra Bandhu, sir, Director, Dr. Rajiv Advivedi, sir, our esteemed Associate Deans, Dr. Raghavendra Rao, Preclinical, Dr. Vijay Kautilya, Paraclinical, Dr. Sameer Uli, Clinical, Dr. Vinay A.V., Student Affairs. It is my privilege to warmly welcome our keynote speaker, Dr. Ashok Jarial, Professor, Department of Physiology, AIIMS, Delhi. So welcome. I would also like to express my sincere gratitude to our dedicated workshop facilitators, Dr. Shival Srivatsav, Associate Professor, Department of Physiology, AIIMS, Jodhpur, who has helped us a lot, and we have completed our workshop in the morning. Along with him, Dr. Mitesh Sinha, Professor, Department of Physiology, Birsa Munda Government Medical College, Shadol, Madhya Pradesh. Those two have done a wonderful job, and it is a heartfelt thank you from our side, sir. Welcome you for the rest of the CME. We are also delighted to have Dr. Madhumita Sen, Assistant Professor, Unit of Medicine, AIMS University, Malaysia, who will be joining us online. She's there online with us. Thank you so much, ma'am. And then we are also honored by the presence of all the eminent speakers, including Dr. Shival Srivastav, Dr. Rajesh Kumar Thakur, Head, Department of Medicine, Tata Motors Hospital, Jamshedpur. We welcome you, sir. Thank you so much. A special welcome to our distinguished delegates who have hailed in from various places, respected faculty members of our MTMC, my dear students, and enthusiastic participants. This truly adds on to the academic gathering. Thank you so much. The final session of today's CME will be featuring an engaging crossword puzzle competition. It is specially designed for our first year MBBS students. We are grateful for the generous support from our sponsors. AD Instruments has been exceptionally supportive in providing the necessary equipments for the workshop, along with RMS, who has provided the portable nerve conduction equipments for the workshop. Biponi and Kalamandir, renowned for promoting the traditional art and culture, have extended their sponsorship towards the academic endeavor. We also sincerely thank JP Brothers for their valuable contribution in ensuring the successful conduct of our CME and workshop. Once again, on behalf of the organizing committee, I extend a hearty welcome to you all. Enjoy the very interactive, interesting, informative scientific sessions and also our hospitality. Thank you very much. Now, I request our Dean, Dr. Harish Chandra Bandhu, to kindly address the gathering. Sir, please.
Thank you, Professor Sindhu, and the organizing team of Department of Physiology for organizing such a educative and informative workshop which you have just concluded probably, or maybe another session is there, plus the ongoing CMEs. I take this opportunity to welcome my esteemed guests who have come from all over India, the guest faculty who will be interacting with us and will give us their thought what is there in diabetes. I also welcome all the esteemed delegates who have registered for this particular workshop and the CME, plus my dear students. Now to welcome you in the traditional, by wishing you all Johar, because you are in the land of Jharkhand, and Namaskar because you are in India. And we all know India is the most populous country of the world today. We are the largest democracy, and we are also the capital of diabetes, Madhumeh. The disease is time immemorial, old, and I was interacting with Dr. Ashok Jaryal in the morning when he came to my office, and I'll tell you, there was a short note of 5 marks, diabetic neuropathy, in my final MBBS examination, which I could not attempt. And today, about 45 years have gone, or 50 years have gone down the line, and today we have reached to this, where the not only diabetic neuropathy, but autonomic system, how do we use it to early diagnosis? Well, I will not stand between you and our esteemed colleagues who are here to educate us and exchange information. I will conclude my views on this and will wish the organizing committee a wonderful time to organize and to host all the delegates and the invited faculties to their best. Thank you very much. Jai Hind.
Thank you, Dean Sir, for your valuable insights. We will now proceed to felicitate the resource persons for the workshop conducted earlier this morning on autonomic function tests and nerve conduction velocity. I would request Dean Sir to kindly felicitate Dr. Shival Srivastav. May I now request Director Sir to kindly felicitate Dr. Mitesh Sinha. Now I'd like to request our Honorable Dean Sir to please declare the session open.
I hereby declare the session open.
May I request the dignitaries to please go back and sit. May I now request the organizing chairperson of this CME, Dr. Srikiti Behra, to kindly introduce our keynote speaker to the gathering.
Good morning to all esteemed delegate, dignitaries on and off dais, and our online and offline participants. Today we have started our scientific session, and with this, it's my proud privilege to introduce a distinguished academician and inspiring clinician, scientist, and our eminent guest speaker for today's CME and workshop, Dr. Ashok Kumar Jarial. Please put a hand together for him, please. Welcome, sir. He is Professor, Department of Physiology in All India Institute of Medical Sciences, New Delhi. He is a widely respected name in the field of physiology, particularly known for his pioneering contribution in autonomic function testing, cardiovascular physiology, and neurophysiology. With an H index of 22, I-10 index of 47, his academic impact is not just impressive but transformative. marking high years of high quality, consistent research that has shaped our understanding of autonomic disorder and their clinical implications. After completing his post-graduation in physiology from BJ Medical College, Government Medical College in Pune in 1998, a chance academic conversation with, you probably know the name, legendary Professor R.L. Bijlani opened the door to AIIMS, where Dr. Jarial joined as senior resident and never looked back. Since then, AIIMS has been both his workplace and his intellectual home. His deep interest lies in cardiovascular physiology with a focus on autonomic function test in health and disease and effect of simulated microgravity. He established the vascular function testing unit to complement autonomic testing services at AIIMS and played a pivotal role in founding intraoperative neurophysiological monitoring at the institute in 2008. His contribution led to the creation of Society of Intraoperative Neurophysiology, which is known as SION, S-I-O-N, a unique multidisciplinary society bringing together physiologists, neurosurgeons, orthopedic surgeons, neuroanesthetists, and physiologists. Dr. Jarial has been a tireless advocate for clinical physiology as an independent domain, and his efforts bore fruit in 2024 recently. After 7 years of perseverance, 11 senior resident posts were sanctioned in the Department of Physiology at AIIMS specifically to provide clinical physiology services. Congratulations, sir. He has received multiple accolades for his work, including 2 AIIMS Excellence in Research Award. Over 25 awards is received by his students under his mentorship, highlighting both the depth of his research and his commitment in nurturing future talent. Beyond academics, Dr. Jarial has also contributed significantly to medical education and administration. He served as Associate Dean Examination at AIIMS for 6 years from 2016 to 2022, during which he successfully transitioned AIIMS entrance examination from OMR-based format to computer-based testing. MBBS students, can take note. He later extended his expertise to national organizations like NTA and NBEMS, shaping the landscape of medical examinations in India. Now, since we have talked in length about his professional life, taking a moment to look at his interest outside professional life, he leads a very adventurous life. In his early years, he was semi-professional choreographer and an avid motorcyclist, often riding to Ladakh and Kashmir. A passionate mountain tracker, and see, it is not for interest. He has completed Everest Base Camp and summited 4 peaks that is above 20,000 feet. Not a joke. Currently residing in AIIMS campus, he has company of 5 dogs. Sir, how do you handle? Enjoys occasional partying too, so not a bookworm all the time. And he recently taken up drumming. Wow, sir. Today, with this, he will speak to us on a topic of immense clinical and academic relevance, one that lies at the intersection of physiology, neurology, and diabetology. Sir, we are truly honored to have you here today. Ladies and gentlemen, please join me in extending a warm and hearty welcome to Dr. Ashok Kumar Jarial. Sir, the stage is yours. Yes. Every weekend he drives 500 kilometers. He goes on a drive that Dr. Suhas has added. Thank you, sir.
At the outset, I'm thankful to Manipal Tata Medical College under Mahe for the opportunity to be with you. I was sharing with the Dean, Dr. Bandhu, that when I joined MBBS, that time of course internet, everything wasn't there, but still then Manipal was regarded as a very high value in eyes of students who were wanting to join medical colleges. Tata has its own reputation in our country, so it's good to be with the leading things, one in industry and one in private medical education. Thank you for honoring me to be with you, one. Second, to Dr. Swikriti, to think of me, to be here. It's a pleasure to be here. So she asked me to give a short write-up of how she should introduce me. And of late, I started putting the last part more. Earlier in my introduction, I was not to put what I do otherwise from academic and administration. That's largely because somehow medical profession, we tend to think that either you enjoy or you study. Then you can't do both. Medical education is difficult. I mean, it's hard work, there's no doubt. But I'm sure there are, if you want, there will be a space for hedonic pleasures of life as well. My responsibility today, we have got 4 talks in the CME. My talk is understanding the autonomic dysfunction. Now, when I look at medical practice, of course, I'm not directly in the practice, but I support services, patients in intraoperative, vascular, and other autonomic domain. What we've understood is that you can practice medicine largely in 2 ways. One is a checklist-based system. You just follow the order. There are instructions, follow the instructions. You will reasonably do good as long as you follow the instructions properly. That is plain practice. You don't really have to understand that if somebody is coughing in tuberculosis, you give the drug, job came. You really don't have to remember what is the pathway for the cough. You don't have to. You can still practice. The same will apply for autonomic dysfunction testing, symptomatology, which will be taken care by these speakers. My job is slightly background. That how do we understand what we do? Even if you listen to what I say and forget, you'll still be able to do good autonomic testing, symptomatology, and treatment. But this talk will help you, if you pay attention, to understand why do we what we do. It'll be helpful for maybe 10% of patients who don't follow the pattern. See, great doctors, good doctors, this is the first talk which I give to students in first MBBS. You read textbooks, you'll become good doctors, more or less. If you want to become a great doctor, you will need many more things. And one of that component is understanding why do you do what you do. So with this, I begin the talk. How do I start? Laptop, yes. Because I'm not able to see. Okay. Oh, it's a bit too right. Maybe I can come a little forward because it's difficult. Yeah. Can you start the slides, please? Project kar dein. So as they are putting up slide, so let me, what I'm going to share with you, this insight that I'm going to share with you has taken us about 20 years. And next slide, please. Just me. Yeah. So whatever I will be sharing with you is, in today's world, information is not difficult to get. Earlier we had books, libraries, now we got internet and access to information is there. The more difficulty lies in making meaning out of it now. I mean, we got problem of plenty. More information but less of understanding. Earlier we had less information, more understanding. Now it's a problem. So my job is to make you understand more than giving you details. So even if you don't pay attention to the micro details, it's okay. You can go back and check. I would be more happy if you follow what I wish to share with you. So I have been working in Autonomic Vascular Test Laboratory, a little background to it. This laboratory was started in 1987 by Professor Deepak, who was superannuated as head of the department and is now consulting with IIT Delhi. So he started this in 1987. It's important to know this because the first guidelines of Ewing's battery came in 1982. So he was a very early adopter of this particular thing as a physiologist then. Then later, I joined him in 2005. And now Dr. Dinu was one of our first MD student, my first MD student, and now he's taking care of the laboratory. So on the operational part, I was helping out till last few years. Now Dr. Dinu does the day-to-day working of the laboratory, and I do what now we call as a Margdarshak Mandal for the Autonomic Function Test Laboratory. Dr. Shival here is also a student from our laboratory, and we're very happy to see him flourish and sit with us. So, we over a period of time we added various technologies. All the work that insight and work that I'll be sharing is because of we have MD students, PhD students, research associates, and funding agencies. So I have to acknowledge their contribution. I'm representing all of them today. And next slide. Next. Yeah. So this is the model that we wish to establish at AIIMS, and we hope that this is going to get followed in the rest of the country. Now we have hospitals who do pure patient treatment. We have pure institutes of sciences, fundamental institutes like TIFR, ICERs, CCMBs, for pure research, universities which are pure research. Medical institutions are the only place where we can bring them together. And that's not just an opportunity, perhaps it's also a mandate. See, if I were working in a hospital system, I do not have the infrastructure for basic research. Or if I'm working only in the fundamental institutes, I don't have patient flow. So where do we come together for translation and integrative research? And this idea is not something that I came up with. Professor Hall of Guyton and Hall. So I read his article in 2002, enlightening same problem that were occurring in US and European countries, not just in India. So what has happened is that, unfortunately, our systems have become preclinical, clinical, and somewhere in paraclinical. Taking out the whole idea of integration completely out of the box. It's not even existing. So this attempt of bringing in autonomic function test function with the Department of Physiology, we are very happy, thankful that it is progressing. So what we believed is that we can contribute in multiple ways. We can help in devising new technique, new testing, or go back finding pathophysiology. Either way is going to go circles, and it takes decades to reach these points. Next slide. Yeah. So I'll be touching upon these three aspects briefly. Details Dr. Shibal, Dr. Madhumita, and others will be taking. So first is, to understand dysfunction, we need to know the function. Largely most of us talk about function, and I'll take you through a different realm. What autonomic function do, what is parasympathetic is too simplistic. And I would love to explain it to you in holistic way. The next is, if somebody has dysfunction, how do we identify it? Which is a clinical issue. A patient comes, and largely what we have seen at AIIMS, the patient comes to us when they've gone through all the departments. They've gone everywhere, and they've not been able to diagnose, and say if you can't either, and before us they go to psychiatry. If you don't find a particular symptomatology, an organic cause of it, psychiatry, and then they send to us, okay, aap dekhiye kuch hai problem. So this, and I will detail about why this is an issue, and why we have to be aware of it. And lastly, the goal of medical treatment is find the cause and do the management, which Professor Thakur, I think, will be covering on these lines. I'll go through this in these domains, functional anatomy, which is textbook knowledge, but I would love to go higher than that, is functional organization. Rather than information, what sense does it make? It will be followed by a brief touching on what symptoms are and how these tests have developed. The list of tests, morning the session was occurred, and there will be another talk by Dr. Shibal on details of it. I will take you through what does a test even mean. How do we develop a test? I'll take you through that. And lastly, a little bit touching upon the autonomic dysfunction and specifically focusing upon diabetes and lifestyle. We are aware of lifestyle problem in diabetes. I'll take you through how autonomic nervous system is related to it, not only as the consequence of diabetic problem, but perhaps as a cause of diabetic problem. And that I'd love to share, because that's a different line. And we have some work in it. I'll share that work later. So this is the regular textbook knowledge. इसका वो एक हटा देंगे, एक जो ये बॉक्स आ रहा है, एक बॉक्स आ रहा है इसके ऊपर. This particular box, can you help it out? It must be from the screen, the projection screen. It's a projector issue, I think. Yeah. Yes. This is the standard textbook knowledge. I'll jump over this. This is not what I want to talk to you, that you know. Okay. Now, some details are required if you want to understand things. Okay. This is something which, unfortunately, most of our textbooks don't tell. Not even the higher textbooks. So I want you to pay attention to this, especially for the students and those who are online. Bear with me for next 4 slides. that will need a little more cognition than the rest of the slides. So this is a diagram of the medulla and pons showing the cardiorespiratory centers. What we have on the right is, then the blue is the nucleus tractus solitarius, where all the visceral information comes through vagus and ninth nerve. DMV is dorsal medial nucleus of vagus, which specifically supplies the viscera except heart, which comes from nucleus ambiguus, which is in front. There's a round area called NRA, nucleus retroambiguous. See, names are not important, locations are. Names we'll forget, you'll forget, doesn't matter, but get the idea. A separate area for dorsal, for the rest of the vagus, a separate area for the heart, a large area called NRA. This area I'll come later, keep in mind. A column called VRC, called ventral respiratory column. So all the Bodzinger, everything is located in this zone. And in front of it, laterally, is the ventrolateral medulla. Names are there. So the outermost, the lateral column is for respiratory, the cardiovascular function. So all the CVLMs, RVLM are located here. What you see is a very small area with congregation of these neurons. Obviously sensing that they must be interacting with each other. And this is the lowest level of organization. Over that, in the pons area, you got fifth nerve and seventh nerve. One is for taste, other is the trigeminal for the face. Important part, because lower animals use whiskers to move around and sense. It's very important for them. And taste part. So because feeding behavior starts largely here, eyes, smell are far off. So evolutionary, what came near your face is a very specific organization. That's very low level. And you have parabrachial nucleus. Please also remember this. This nucleus takes information from all viscera and is your alarm center. So when you're sleeping in the night, and if you wake up because you have got to go to washroom, what wakes you up? You're sleeping, something crawls on your leg, you immediately wake up. What wakes you up? The parabrachial area in the pons is that area. You walking, you hear something, you stop, you freeze, you stop breathing, parabrachial area. Its older name is apneustic center. So, but we should not use that term anymore. It should be called as parabrachial area. No, not those names. And then 5 now. So this is the basic understanding, because it is all around this. All of the autonomic function tests are working. If any test that you do of Ewing's battery, you put hand in the cold water, there is a reflex. You ask yourself, what is the pathway? You do HGT, what is the pathway? Because there are separate pathways for these tests. And if you are smart enough, you do this test in a patient, it may not follow the exact pattern of written textbooks, but if you know the background pathway, you will say, oh, this is that path involved. And I'll show you some research that we have done on this aspect. Little more detailed slide, okay? But please bear with for next 3 slides, okay? What is ANS doing in homeostasis? We know what homeostasis is. On the left, lower left, internal state of the body and body surfaces. We get information from there because the thermal information largely from the skin. I talked about itch. So itch reflex is there, we scratch. You don't have to think. Dogs don't think. They have some itch, they will scratch. It's a reflex. These reflexes, some are spinal level, some are medullary level. So these reflexes lead to, on the right side, 3 outputs. An endocrine output, some change in the hormonal secretions. Low glucose, something gets released. Cortisol gets released. And a neural mechanism of sympathetic stimulation or vagal stimulation, whatever the case may be. So we have endocrine mechanism, a neural mechanism, and lower down is the motor response. We also do the motor response. For example, respiration changes, swallowing occurs, coughing occurs, vomiting may occur. These are all internal mechanisms. You are not thinking. You don't even need cortex for this. It will happen. So these 3 outputs are there. And the NRA, which I spoke of, is that symphony creator. It controls these behaviors, motor behaviors. Of course, it has a top-down control. So if you had an animal who only had medulla and pons with the circuitry, it will have a vegetative functions, no problem. It won't be able to go fend for food, look for a mate, but it will survive. You don't need cortex for survival. Coma, as long as you keep giving people TPN, total nutrition, take care of the ulcers, person will survive. People do survive in coma for decades, indicating that for our vegetative function we don't need it. Then why do we need the rest of the system? Or is there a need for rest of the system for autonomic nervous system? Reflexes here, all reflexes, cardiovascular, you think of respiratory reflexes, GI reflexes, all can operate at a lower level. What I'm showing you is the hypothalamic at the top center, and this is homeostasis only. But animals don't just do homeostasis. We also have to interact with the environment, and that's where the higher systems come into picture. So ANS gets modulated during these behaviors. So if one has to run, now you can't let the CVS operate at its homeostatic level. BP has to be raised. Heart rate has to be changed. The respiratory system has to change. The GI has to change. The glucose level has to rise because you need to run. So it is changing you from your homeostatic state to a new stable state. So it's a new stable state, and it's the change. Is it good for us? Temporarily, yes. Stay there for long? Not good. And this is where I'll be touching in the last as to why lifestyle modifications through this system becomes a problem. So we have on the right side, defense behavior, all animals have it, fight, flight, ANS responses we talk of. The exploratory behavior, animal has to go find new areas. And there is anxiety, the attention. It is preparatory stage. What we call anxiety is largely a preparatory stage. It's not a problem. It has to be there. It's a protective mechanism because you're going to a new area. You don't know what's going to happen. So the first time you speak on the podium, same response. It's a new area for you. You do not know what. Okay? You may not have physical threat, but there are psychogenic threats. Or we have been fed. So on the left side are the benefits that we have of our cognition, our higher mental abilities, but also so we have psychogenic, hedonistic, and cognitive abilities. But they can also then lead to stimulation of the autonomic nervous system when it's not needed. If we were to take, if you remember the last match that happened with Magnus Carlsen, and so what did he do when he lost? He banged the head. Why would he do that? It was just a reflexive mechanism. He displayed a motor behavior of fight or flight because the same system was driven. Animals don't do that. If we eat dogs, they decide the hierarchy and they are happy. They don't question after that. They just test once. They largely don't kill each other. They just try to push their hands. Who's the boss? When the boss is decided, they sit quietly till the next opportunity. Primates fight more. Monkeys, gorillas, we fight more than the lower animals. And of course, humans have reached a entirely new level of. We reach an entirely new level of interaction. So, what happens is which areas now get into this picture? So, I had shown you the picture of medulla. I brought in the hypothalamus as a central for homeostatic purposes. Now, we're going to higher level where I'm bringing in motor control areas which are higher than the reflex areas. Okay, but they will of course operate through the lower areas. And on the extreme left, 4 areas are marked. DLPFC, dorsolateral prefrontal cortex. This is the area for executive function. I'm preparing my slide. You're preparing for your exams. That process is executive function. Whether you want to prepare for exam is a psychogenic motivation. I want to dress well. I want to come first. That is a different drive. How you do it is dorsolateral prefrontal cortex. Then you have lower one or orbitofrontal cortex, the lower part just above the eye. This is your balance system. Is it good for me? Do I like it? Should I do it? Tastes good? Throw away. Lowest level. Doesn't taste? Throw away. Lowest level. Getting educated has no hedonistic drive as such. What pleasure do you get studying for 18 hours, 20 hours? What pleasure does the doctor get for waking up for 24 hours? It's not the physical pleasure, because the orbitofrontal cortex along with the prefrontal cortex thinks it's a pleasure. That's what our culture teaches us. And that is something humans, that's why we are humans. That's why we have all the creativity. You've ever seen a monkey make a house? Never. Monkey has seen so many houses, monkey has seen people wearing clothes. Monkey has never thought of making a cloth for himself. Not at all. Because they do not have that particular system. We have it. But we also suffer a consequence of it. Consequences is that we now activate our autonomic nervous system when it's not supposed to be activated. I could drive, I could play a match without having to raise my blood pressure. I could take a lecture without having to be scared how people will think, will my lecture go good or bad? This is something that and this we learn with time during our childhood. What's important, what's not important. I've marked basal ganglia specifically. The traditional textbook knowledge tells about basal ganglia. Basal ganglia has motor functions, and its dysfunction leads to 3 problems: Parkinson's disease. It's true. It's not. But what does it do in the motor system is something which I want to share with you. We speak of, and again, it's a planning area. Actually, it is incorrect. It's incorrect. What it is, it's actually a learner by reinforcement learning. And those who are aware of AI, it speaks of reinforcement learning. What is reinforcement learning? You learn something by reward and punishment. It's the basal ganglia, dopaminergic system, dopamine inputs from the brainstem as well as from the orbitofrontal cortex. Both comes. We generally speak of substantia nigra into basal ganglia. Please remember, it also comes from the anterior part. So this is good for me, this is not good for me. It stimulates. What does it reinforce? A behavior, a motor behavior, an emotional behavior, a cognitive behavior. If you speak to somebody nicely, they respond well to you. Where is it getting memorized? In basal ganglia. It has motor functions. In humans, the motor sensory part is very small. The anterior part of the whole thing is largely for cognitive functions. So Parkinson's patients do show cognitive delays. They show emotional delays. Whatever they happen in the motor system also happens in other domains. And therefore, other part basal ganglia does is, when after motor learning has occurred or cognitive learning has occurred, how should I respond? Somebody says, so depending on where you are grown up, if you have a car accident, the way Pune used to respond and the way Delhi responds to the car accident is entirely different. In Pune, they come out and say, in Delhi, they don't talk. They start something else. Okay? And they take up their hand and, do you know who I am and whom I know? These are learned behaviors. Which behavior to exhibit at that point in time is the function of basal ganglia, which is called as action selection. Whatever you have learned over a period of time, in this particular moment, which behavior to express is the function of basal ganglia. And basal ganglia also does another thing, that it leads to formation of habits. Now, how are habits different from hedonistic behavior? You start something for pleasure. If you continue to do that thing irrespective of the pleasure or punishment, it's called habit. But now you do it not for pleasure. Now you do it despite the punishment. Then we call it habit formation. And basal ganglia is that area which leads to habit formation. Thereby meaning, if I do something initially for either physical pleasures or mental pleasures, do it for a certain period of time, you will continue to do it now even if you don't want it. That's what habit formation. And this, if incorrectly habituated, if incorrectly learnt, will begin to trigger autonomic nervous system or not. Okay, this is the line. So, if there is modulation during these behaviors, defense behavior we understand. Now, humans have the ability of abstraction. We abstract. I should be afraid if there was an actual lion in front of me. But why should I be afraid if there is an examiner in front of me? The examiner is not going to eat me. But we know how our responses are. Because we have somehow linked this process as having some problem to us. System doesn't understand that. When we watch a ghost movie, a horror movie, we know it's just a screen, something is coming on that. But most of us get scared. Something occurs. We also jerk out. Because the cognitive system knows it, the subconscious system does not know it. And if you have not trained the system well, it will get activated. It will get activated. So this is where, so when it gets activated, it leads to increase in blood pressure, for of course cardiac output, glucose level, suppression of immune system, coagulability, water retention, many more. Okay? So for animals, fight flight is minutes. See, I used to watch a documentary of any wildlife, herd of deer, grazing, tiger comes, eats one of them, whole thing gets done in 5 minutes, tiger goes off, they start grazing again. No deer now thinks when will the next tiger come. They don't worry about it. They don't have the capacity to worry about it. We have the capacity to worry about it. This capacity to think, to go back and forth has given us creativity, but it also has given us the problem that ये सर आ गए तो डांट पड़ेगी. Animals live in present. We live in past as well as future, and we go back and forth and then create our problems. So, and it can go on for days and months. So imagine your autonomic system inappropriately activated, which should have been activated only for a few minutes, now activated for months. I'll give you an example, so in pregnancy, hemodilution occurs. The hemoglobin level, constant, the overall value goes up. More hemoglobin, more blood volume, but the hemoglobin level drops by 2 to 3 milligram to gram percent. What benefit does it have? Why drop it? If you see from the perspective of physiology, it's largely protect the heart. Because mother would now not be pumping 5 liters, would be pumping 7.5 liters, 30% more maybe. Okay? That blood is going. It's almost as you're walking. A resting person versus a person who's slowly walking will have that kind of raise of cardiac output. So the pregnant woman would be having that cardiac output high for next 5 months when the blood volume goes up. It is too much load on the heart. It could lead to actually cardiomegaly. And if in her nature she bears children continuously over a few years, you are exposing the mother for large period of heightened cardiac activity. The hemodilution decreases the viscosity, decreases the resistance to the flow, and therefore decreases the workload. That means it's such a small thing nature has taken care of. If we can understand what will happen to us if our BPs are shooting up every 10 minutes when we are walking, crossing the road, meeting somebody, going for a date, we'll be waiting for our results, BP shooting up. How many times a day? And the way our lifestyles are, perhaps 100 times a day, 200 times a day. How long does it last? So what could affect a mother where nature had a solution? You can imagine the trouble that it can give to us. As I brought that example. So this is the lowest level, pontomedullary reflexive level, cardiorespiratory, above that neuroendocrine level, and drop conscious systems that we have. And basal ganglia makes a conscious system into a subconscious system. First time you start doing something, makeup or something, you take time. After some time, it just happens. It becomes basal ganglia level. This is to decrease the cortical energy utilization. It's very expensive. Run the cortex, brain takes 20% of your oxygen consumption. It runs only on glucose. It's really huge. It's not even physical. It's just sitting there doing nothing. Only spikes. Imagine the amount of energy it needs. So what happens in our day-to-day activity, about 80 to 70% of our activities are subconscious. We do reflexly, which is basal ganglia. They have been learned over a period of time, stabilized. Can you change it? Answer is yes. We can change it. But you have to again re-practice it. It won't just change by cognition. You have to keep doing it. So this was the early part, and this largely what I wanted to share with you. Now I'll quickly go through the next part. How do we identify the dysfunction? Obviously there are symptoms, there's clinical examinations and laboratory tests. Let's look at the problem with autonomic symptoms. They're very non-specific. खाने के बाद ठीक नहीं लग रहा. It could be say खाना ठीक नहीं खाया होगा, जल्दी खा लिया, बाद में खा लिया. There are so many explanations that we can have which are non-disease, or it could be really a problem. Okay. The non-specificity can occur in all these systems. Many of us sometimes have also gotten up and felt a little dizzy just because we were dehydrated, got up suddenly. It can happen to us. It's not a disease. It's a functional decompensation. The astronauts come from space. They have to be carried because they can't stand, because the BP will fall. Nothing has gone wrong, it's just decondition. You have to get it back. So this makes it difficult to, that's why people come to autonomic function test laboratory after they have gone everywhere, where you cannot find an organic cause. Then maybe it's a neural cause, and we don't not have a technology to look at it. If you have to develop a test for anything, there are these three possible ways. Observe something that is happening. So when we do HRV, you're doing nothing, just looking at the heart rate fluctuations. You're doing blood pressure sensitivity, looking there. You're not giving any stimulus to the patient or subject. Next group is trigger a reflex. Do something, and let's see how you respond. So give a cold pressure test, hand grip test, do some activity. These are reflexes, subconscious. Or we could then make them do some activity. do mathematics, do this, make them do some cognitive activity, or trigger a phobia. You're scared of lizards, show them a lizard, they'll respond. That's triggering a top level. So we can do all these three things. What we're going to do then is standardize the task. How much code, how much to put, how much hand grip, whatever. You standardize the task. Also standardize the stimulus. Say what mathematics to do, how much to do, what emotional test you are giving to somebody has to be done. Once you have done this, you measure the parameters in large population of healthy and not so healthy people and do two things. One mechanism is what called ROCs, receiver operator characteristics. This was used to detect planes in Second World War, this particular technology. We are now using in medicine. Determine cutoffs, or you do percentiles. Everybody within 95 percentile is normal, outside is not normal. This is one way where we don't bother about disease or not. Other is, there's a disease, normal, we do a determine cutoff. This hemoglobin below this, medical practice is cutoffs. You have to know above this, below this. It's not a linear thing. So when a physiologist says tachycardia, it's increase in heart rate. For a medicine person, practicing person, more than 100. Cutoffs are needed. Otherwise you can't do medical practice. So this is the basic idea. And this, I'm raising this because the tests have changed. How we interpret them. Next screen. Next. Yeah. Quickly run through without going in details. The whole thing started somewhere in 1930s. Use of tilt table was done. Use of blood pressure responses in Valsalva maneuver and heart rate for fetal distress, which we still use in obs and gynae. Heart rate fluctuations. It's basically ANS fluctuations. They measured it. Good, not so good. Cutoff criteria. Important is this Sir Roger Bannister, and I will talk about him. This guy was the first guy who sat down and said, okay, let me measure everything. We don't do the whole thing today. So he measured Valsalva, tilt table, suction, thermal, even ice cold, back, and mental arithmetic. We don't today, but he did. And even that time he measured actual blood pressures. In recent past, we were not measuring radial, intra-arterial. We measure from outside. He did that. And this is the diagram that he published. So Roger Bannister single-handedly established autonomic function. He's a neurologist, passed away a few years back. He's also, I like him more, or I have regard for him more for something else as a physiologist, less of him as a neurologist, because he's very valued. And for this reason. So Roger Bannister came up with the book, of course, first book on autonomic disorders. But he was also the person, as a student of MBBS, who broke 4-minute a mile record. Before this, in 1954, nobody thought that one could run a mile within 4 minutes, and nobody could. He changed the way he trained on the basis of physiology. He ran, measured, and failed. For this, he changed the complete, what we call HIIT today, high intensity interval training. He did that. So he used to run first round, 400 meters, at a particular speed, wait for 2 minutes, again run at a faster speed. So he escalated. And he was to win gold medal in Olympics in the mile race, but he did not, because there was other guy who knew his training and they psyched him up. They planned to make him break his schedule. So they ran a bit faster earlier, so he also ran faster earlier. And then he lost his glycogen to continue the race. And I mean, he raced, of course, but he lost. So this is where the physiology, and therefore it changed. What you call sports physiology effectively began with him. It would be a good idea if you can. There are a couple of movies based around this idea. You may watch a movie called Chariots of Fire. Those are not based upon him, and there are a movie called 4 Minute. A very interesting thing. And of course, this is Olympic. He was the holder of the flame. Okay. In the 1970s, research was done, and Ewing came up with 1982 a criteria. This is very difficult to do, intra-arterial, how we do it in practice. And therefore Ewing made it simpler and brought it into the practicable. आप public में कैसे करेंगे उसके लिए वो लेके आए 82 में. Dr. Deepak, of course, I told you that adopted this in 1987 for AIIMS, and we started doing there. Now the lower part, upper part Shival will tell. Their assumption was first the parasympathetic occurs and then the sympathetic occurs. Therefore, if you have sympathetic problem, higher level of dysfunction. Okay, this was the idea. Next year, Belaware came, and when I read the paper, I think they were colleagues. And in this publication, I think Evans did not give him the authorship. So he came up with parallelly another paper with a slightly different system, and he gave a scoring system rather than, but he didn't separate as a progression. So he said, doesn't matter whether parasympathetic, just add up and give a score. Because people who research also have a life. They have their own characters, and it's useful to understand them also in their research. It makes it easier. It gives a face to the name. Then there was a conference of people, of experts, and they further suggested it is parasympathetic to sympathetic. That was the idea running around. In 2003, HRV was added up, and again we started doing HRV at AIIMS earlier than that, but it was adopted as a consensus. See, the issue is that you may do, but does the world believe you? So, and world is experts, so they said this, fine. We, since we are doing lots of patients and we are analyzing the patient, what we felt that during the patient, some patients would come with only sympathetic, some would come with only parasympathetic, some would come with mix. So we suggested that you have independent things, have independent scoring for sympathetic, have independent scoring for parasympathetic. This was a paper publication. Then this consensus came in 2021, where if you see on the left, they clearly say adrenergic tests and cardiovagal tests. Clear definition. When the paper came, I immediately thought they may have quoted our paper. You feel ना अपने काम किया तो आपका पेपर कोट होगा. मैंने सब सर्च किया, नहीं था. So I felt a little disappointed that maybe they didn't get it in the publication, maybe it's not available to them, whatever. So one of the, and most of the people in the conference we meet, so I met this guy, Mark Hales. Hales is a dominant name. So I thought of bringing up to him कि भाई क्या हो गया है, इतना कराया था, हमारा नाम भूल गए हैं कि ये चीटिंग क्यों है. But then this was an informal meeting, so sort of they left it. But this happens to all of us sometime or the other, that you may come up with something, you may not, but it's okay. Important is to publish. It's still there. It's there, and when somebody will dig out, it will find out. Now what this new scoring system does, some changes, which may be of importance to those who are in practice. One, it goes for percentiles now. There are no cutoffs now. You have to have your own lab percentile. The same thing is done for NCVs. When you do NCV, you are expected to do your own percentiles before you make. You don't do a world cutoffs. It requires beat-to-beat blood pressure with a device. Earlier we did not need it. And percentiles. So at AIIMS we shifted to that. Of course, equipment costs and there are other things, issues involved. But then when there are guidelines, if you require airbags as the rule, you can't say, I don't want to, because it's a practice. So we may be forced, but doesn't mean evening battery is incorrect. Evening battery still runs. Okay? So, but awareness is useful. Last leg of my talk, determine the cause of autonomic dysfunction. Ye sab ho gaya. As a clinician, we will look at the course, localized, general, structure, function. This is the way we do any approach to any disease. When you look at the classification of autonomic dysfunction, there are plenty of classification. I've tried to do a different way. Maybe you like it, maybe you don't like it, but listen to what I feel, how it should be done. It's a primary neurological disorder. There's some problem with the nerves of ANS. And it could be any of these. It could be neurodegenerative, MSA, others. But the problem is in the nerves directly. On the other side is, ANS is a bystander. Something else is happening somewhere else, systemic problem, and ANS gets the hit. Okay? So which will come from autoimmune problems? Something else has occurred somewhere. And auto antibodies have been formed and they hit you. The problem was not in the nerves. It got affected. So one side is where the problem is in the neural system. On the right side is the problem not in the neural system. And below are the metabolic, where we're talking today of the one. Of course, diabetes is the largest one. There are others, of course, vitamin deficiencies, uremia. Okay? We should not underestimate vitamin deficiencies in our country as a problem of neural function, including autonomic. We incidentally had one of the cases of lead poisoning a long time. Patient came, complete loss of autonomic function. Took the history, working certain factory, which we knew were working lead. So, hat jao, 6 months it returns. The function returns. I specifically wrote lead over there because it's a problem in many industries in India. Okay, batteries are there now and it's going into our environment and many of us will be eating that. Functional side, you don't really find something structural or organic, but still there's a problem. So all the POTS, all the compensatory migraine, epilepsies, they have associated ANS symptoms. The lower one on the right side is diseases which may mimic ANS, but they're not ANS problem. So these are thyroid dysfunction, sweating disorders can occur, adrenal dysfunction, pheochromocytomas. Nothing wrong with the ANS, just a effect on it. Doesn't cause change in it. These cause changes in the ANS on the right side. Systemic disorder, change ANS. They just make it respond in that way. Don't change ANS. Last is the lower, maladaptive inappropriate activation of ANS, which I spoke earlier. When we look at lifestyle, this is what is happening. Now, this is the idea which I wanted to share with you. As of now, what we believe is an increase in the glucose level and all the products and leads to a problem in the nervous neurons. But I do believe that there is a path before pre-diabetic stages or early diabetic or non-diabetic, wherein it is the inappropriate activation which is continuously leading to high glucose, spikes and spikes and spikes. The neural system is continuously bombarded from top. It leads to changes in the level of medulla. Reflexes get retuned. The way it happens during exercise. In exercise, baroreflex, does it work? If it's working, BP should not rise. The BP rises because reset to a new location. So when we are running, BP set to say 120, about 130, 140, 150, stays there as if we are running, comes back. If baroreflex was working, it should not allow it to rise. It is reset to some level. Resetting occurs. It's a natural process. You keep resetting it every few minutes, continuously for a month, it resets to that level. And what we call essential hypertension is my belief, that it is this multiple triggering. Therefore, when we are looking at solving the problem of autonomic dysfunction, one of course is that management problem. We have to take care of the disease. Also, we must understand that in the large population that we are saving, how do we take care of this? Now, one common way of taking care of this, what we call meditation, yoga, other things. Dr. Bijlani, who sort of started integral health system in India, so we should talk to him, and he used to say that the problem with people who are practicing yoga is they think the 1 hour of yoga is good enough. You go practice meditation for 1 hour and 23 hours, rest of your life, you are blasting people. But it won't work. It won't work. Because you look at the percentage time that you are shouting at people, getting upset, and then you're doing yoga. And this is an unfortunate problem. I've seen, there are some people, of course, who are in a way, or day-to-day lives, they are very happy. They are happy to people. Their system is not getting activated left, right, and center. And there are those of us who are always on the high. Okay, either psychogenic or social or something or the other. How many likes I got? I did not get likes today. Social pressures. You're worried, checking every day. It's a pressure. It's spiking your systems. Oh, somebody sent a friend request to me. It's an exploratory pressure. It's an exploratory idea. You don't know who the person is. You begin, anxiety level goes up. You're shooting. So this deconditioning has to occur. And this deconditioning is something that it has to occur within you. Therefore, only doing a yoga asana or practicing meditation, my understanding, for 1 hour won't change anything. Rest, 17, 18 hours of your waking time, wherever you have to wake up, what you do, how do you behave. So it's a behavioral change. Your basal ganglia has to learn not to let the action, not to let, if my senior faculty is walking in, I should not get scared. I have to teach my basal ganglia. Don't get scared. Don't initiate your ANS systems. Don't get emotive. Train. You need practice. And that's what yoga actually is in its essence. If you do your work happily, if you meet people happily, you're doing yoga only. Okay? You don't have to really sit down. So there is a physical part of yoga which is also required, but this is the mental part. This is the psychic part. This is a human ability. The ability which makes us talk, makes us do everything, is the same vulnerability. And we have to understand this. You cannot think and let it go. No matter how much you think this is a movie, I should not get scared, you do get scared. It's a subconscious thing. It is there. Your system has been triggered. Hardwiring is there. We have to overcome that hardwiring. So this was largely the part which I wanted to speak to you. I will take few minutes just to rush through what work we have done in this regard. Okay. So this is some work that we did very early. One issue with MSA, P and Parkinson, how to differentiate the two. Larger that you give a trial of Parkinson treatment, if it doesn't work, it must be MSAP. That's the more or less line of thought. We thought of looking at the autonomic function, and Dr. Sankanika, she was MD student then. She did this work, and now she's pursuing neurotraining in UK. Okay, so we published this data, and we felt that the CVG during cold phase, and this would be helpful. Then we further looked into spinocerebellar ataxia, because AIMS has these patients coming to us with good cohort. Dr. Achal Srivastava is a neurologist with us. He's a movement disorder person. So Dr. Debashri, she was a PhD. She did this work. Again, we published this work showing that this was more of documenting rather than pathophysiology. The first one was finding a way if we can help out in diagnosing, differentiating. This way was more of documenting what happens in SCA for autonomic dysfunction, just documentation. So similarly, we worked on some Rett syndrome children, adolescent also, other publications. Then we also looked in metabolic syndrome. What is happening? And interestingly, if you see the top publication, we looked at non-alcoholic fatty disorder. They did not have the other problems of metabolic syndrome, but they have changes in the autonomic dysfunction. And we're wondering, now the person doesn't have metabolic issues, has fatty liver, it has already changed. Now is it going to contribute to it, or is the cause of it? We don't know, because we can't do that kind of cause-effect data. But as early as fatty liver disease, this is happening. It's a alarming thing for us. But then patient doesn't have symptoms. Okay. A bit of hardcore physiology, again may be useful for medical students, and will help us in understanding when patient lose blood in trauma or in the operation theatre. Today, if anesthetist has to give blood, the decision is dependent upon only on the heart rate rise. If the heart rate बढ़ गया, that means the compensation has gone up. You may lose 15% of your blood, BP may not have changed, because the system is compensating. First 750 ml, even heart rate won't change. You may lose 400-500 ml of blood, heart rate doesn't change. Who is compensating? Compensation largely venous. The system becomes smaller. So we're looking into this, and this is part of this is the fourth study in series, about 15 years. This is the last one which I'm sharing with you. So we looked into what happens in the early part of the blood loss, 400-500 ml. What we came up with the idea that in the early part, non-hypotensive range, baroreflex doesn't operate. Okay, it is largely cardiopulmonary receptor reflex, and it's very strong. In fact, if baroreflex begins to get into picture, you already lost the compensation of the volume. It's already done. Therefore, in clinical practice, would it be important to check this early losses? How much you have lost internally? So now another study which we have not published, we have come that perhaps the carotid dimension changes or fluctuations may be important, because even if you lose 100 ml of blood, arteries become stiff, but not the baroreflex. It's not yet started, but arteries become stiff, and this is shown everywhere. We've also shown that this was a MSc study. She's now appearing for exam, so we'll publishing that. So idea is we are thinking of that if early age of blood loss, you could do the fluctuations in the carotid with the ultrasound probes, and you look at the changes in the fluctuation, which will give an indicator of how much blood you have lost. If now baroreflex come into picture, then it's the next stage. That's all. So perhaps in time, this will become a different way of classifying hemorrhages, early part. But something, and this is also important because we published it in a, we're very happy. See, there are certain journals that you're happy to publish in. Journal of Physiology, American Journal of Physiology, they're top-notch journals. This is the older Journal of Physiology, Fluger's Archives, and they accept our papers. We're very happy for that. I'm sharing with that to you. These are the psychogenic motivations. They don't give you anything, but you feel good about it. Okay. Then we were working in preeclampsia, Dr. Garima and with the obs-gynae, to know what happens, why it happens, and we've come out with ideas that in the early part, what goes. Because the problem is, can you pick up a woman in first trimester and say she's going to become preeclamptic? That is the, so we've been trying in that domain. Another PhD has been done, so we'll be submitting those later. So publications, I'm closing with acknowledgements. It's important to remember where we come from, and the Google search says, paraphrases, we rise on we stand on we go higher on the shoulders of the giants. We all are incremental. Somebody has helped us. So for me in this journey, I had my guide for MD, Dr. Professor Prem Kumar, who suggested after my MD viva, कि ऐसा करो एम्स चले जाओ, यहाँ मत रुको, यहाँ पर आपका आगे ग्रोथ नहीं होगी. Then of course Dr. Bijlani gave me the opportunity, and these three people, Dr. Rao, Dr. Ghosh and Dr. Deepak, have been very instrumental for me in different domains. Dr. Rao and Dr. Ghosh was not my lab people, but they were people who had to talk in seminar rooms, academic discussions. They gave me way to think. Dr. Ghosh was very good at methodologies, so he made my methodology perfect. Dr. Rao was thinker, philosopher, so he made me think in a different way. Start looking, the same data, think in a different way. And Dr. Deepak, of course, he was very good in management. He could get funds. He could do everything for us. So therefore, these people are very important. And with this, thank you very much for giving me the opportunity to discuss with you.
Now the session is open for discussion. Anyone? Yes, ma'am. Dr. Sunita Tripathi.
For the guest speaker, usually questions are not asked, but because sir told just I want to ask sir. So as he told, every time the lady gets pregnant and due to the changes in the volume, the heart may fail later on. One question. Previously, the ladies were having 9 to 10 children. Why by the time of 10th child, she was not having heart failure? Just one question.
I will go to the heart failure problem. I will reach to the limit to cardiomegaly because of the compensatory hemodilation. If she did not have compensatory hemodilation, I believe it would have happened. Of course, you can't do experiments for these things. Because blood volume is high, cardiac output is high, the workload on the heart is high. Now the only way to offset is dilute the blood. So hemoglobin goes low, viscosity goes low, afterload becomes less. And between the volume overload and the pressure overload, the pressure overload, which is resistance based, is much more damaging to the heart than the volume overload. As a clinician, we know. I mean, the aortic stenosis has more chances of MI than the aortic regurg or something because of that problem. So that is the line. That even that's what I said. Even they had many children. It is because of hemodilation the heart was protected, and therefore, if the nature has chosen that line, or the line has got chosen during the course of evolution, why should we underestimate 100 minutes, 200 minutes of everyday shoots of BP for us, everyday shoots of glucose for us? Not because we ran, not because we ate something, but because we activated autonomic endocrine system inappropriately for the situation. Coming here and giving a talk should not make my BP rise. You are no threat to me. Okay? But I may have created threat to me. Psychogenically, socially, cognitively. I prepare for this lecture. It takes me a long time to prepare these slides. I generally don't copy the slides from anywhere. All the lines have to draw. It takes me 2 hours to make a slide. During this process, am I tensed? Am I worried? Or I'm enjoying it? It will change the way my ANS is responding. If you are enjoying it, very good. If you're not enjoying it, it's a pressure on you. 2 hours, okay? The BP will be up, glucose will be up. So you are basically conditioning yourself to be reset for metabolic syndrome. That's the line I feel. If you ask me, where is the evidence? I can't, maybe can produce evidence, but logic remains. Thank you, ma'am.
Thank you, sir. Can we take one more question?
Autonomicity or autonomic system is the grace of God. We survive in all the situations we face. Sir, सब लोग यहाँ आए होंगे. Autonomic dysfunction is बाप रे बाप क्या चीज है, हम लोग कोई ना समझते हैं ना करते हैं, स्पेशली झारखंड में तो. लेकिन यहाँ आकर आपसे जब सुनते हैं, आपका सभी लेक्चर लोग सुनते हैं, ओह यही था, यही था. Sir, you have produced autonomic function assessment and given a very good backup to all the scientific personality of this country. Understanding of autonomic function is इसको समझना करना इतना आसान है। और आज सुबह में सहबाल इतना सुंदर से वर्कशॉप लिए, किसी को भी समझ में आ जाए यहाँ आने का फायदा। सर, वेरी सैल्यूट टू यू, यू हैव डन इट वेरी वेल, थैंक यू।
Sir, just some of the students when they are going for talks or lectures, they generally ask me advice. So कैसे बनाएं? I say, what is your purpose? To impress or to communicate? You decide that first. If you want to impress, use jargon. ऐसे ऐसे शब्द बोलो, लोग घूम जाएं कि ये पता नहीं कुछ बोल के क्या समझ ही नहीं आया। ठीक है, वो सवाल भी नहीं पूछते, फिर समझ ही नहीं आया कुछ भी, but they get very impressed. If you want to communicate, you have to slow it down. Details, of course, you can't remove the details, but this is the way of speaking. But then it also exposes you to lots of questions. So be ready for that. So I have chosen the line to be open to questions. I enjoy the whole thing. So more questions that people ask helps me only, because then after that, ये भी तो सोचना था, ये रह गया. So in a way, you help me out. Humans have a very typical nature. You tell somebody ये paint wet है, हर आदमी जाके टच करता है, कोई नहीं मानता आपकी बात. ये वेट है, वो टच ही करता है. यू टेल देम वो मून पे हमने लैंड कर लिया, हाँ कर लिया होगा. नोबडी क्वेश्चंस दैट, बिकॉज ह्यूमंस विल डू क्वेश्चन व्हेन दे कैन. इफ यू क्रिएट एन एनवायरमेंट वेयर दे कैन, दे विल. दैट्स इनेट टेंडेंसी. सो एज अ टीचर you can create an environment, take them to moon like stuff, they will keep quiet and do nothing. You slow down, you sample down, you make it easier for them, they will start asking questions. And so that's the test. If students ask questions, they are sitting here, some of them I was noticing were busy still with their laptops and pads, which is also fine. So when I take a class, so of course students are there, say ऐसा करो यार, जो लैपटॉप लेके बैठे हैं वो यहाँ चले जाओ, okay? और जो सुनने आए वो यहाँ जाओ, ताकि मैं इनसे बात कर दूँ, हैं? Because you get disturbed. Human nature. So because we look at eye contact and your behaviors, if you're not paying attention, तो हमारा भी motivation जाता है. So I request the students also, see, lots of things you will do in life, okay? Some things we attend because we are asked to attend, something we attend because we want to attend. Combination of both is good. There is something in collective wisdom. If your faculty have requested you to come here, there's a collective wisdom in it. Don't discard it. All the same time, so faculty की भी ज़रूरत है और students की भी ज़रूरत है to communicate. Right, thank you.
Thank you, sir. Thank you, sir. Not only we learnt about autonomic function test, we also took lessons on how to take class and how to let them sit in one corner. Thank you for that, sir. Sir, you truly explained that how the autonomic nervous system makes a web which connects every system in our body, and how training it helps us in having a healthier mind and body. Thank you very much, sir. Your keynote address was truly inspiring, informative, and gave us a perfect head start. Thank you very much, and it was a very insightful and wonderful keynote address. Now, to felicitate our keynote speaker, I'll request our Associate Dean Preclinical and HOD Forensic Sciences to felicitate our keynote address. Please, sir.
We now announce the commencement of the scientific session. May I kindly request Dr. Shilpa N. Bijur, Assistant Professor, Department of Physiology, to introduce the speaker for the session.
Very good morning to you all. I hope you have enjoyed the session till now, and many more to come. It gives me immense pleasure to introduce a distinguished speaker, Dr. Madhumita Sen, a seasoned medical professional with a rich blend of clinical and academic experience spanning over 3 decades. Dr. Madhumita Sen is a graduate of an prestigious Armed Forces Medical College, India, and currently serves as an assistant professor and deputy director at the Clinical Skills Center, AIMS University, Malaysia. She brings with her over 15 years of teaching experience in Malaysia, along with prior clinical roles in the Indian Army and the UK's National Health Service and community-based primary care. Her academic credentials are equally impressive as well. She holds an MSc in diabetic care from Warwick Medical School, UK, and a postgraduate diploma in geriatric medicine from IGNOU, India. Her areas of special interest include geriatric medicine and diabetic healthcare, with a strong focus on lifestyle and dietary interventions for disease prevention and health promotion. Dr. Sen is also a prolific author with numerous peer-reviewed publications and a book to her credit. She has been a speaker at multiple national and international conferences and is actively involved in research curriculum, development, and clinical education. Please join me in welcoming Dr. Madhumita Sen. Ma'am, we welcome you. The session entitled Approach to Diabetic Autonomic Neuropathy in an Outpatient Clinic will be moderated by Dr. Sunil Nandwani, Senior Consultant Physician at Mercy Hospital, Jamshedpur. I kindly request, sir, to moderate the session. And it is, ma'am, are we audible? Madhumita, ma'am? Yes, yes. Okay, ma'am. Over. Yes, ma'am. Yes, ma'am. Over to you, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you. I'm sorry I am intruding into your lunchtime. I hope none of you are very hungry. And I hope that you will be around to listen to my talk. Screen, but it's not showing up. I first want to say a big thank you to Dr. Jaryal, who gave us a crash course on autonomic nervous system, which I really needed because I seem to have forgotten all my physiology. So thank you, Dr. Jaryal. Can my screen be shared? Shall I start?
Ma'am, it is shared. You can start the session.
Okay. So we have learnt a little bit already about the diabetic autonomic neuropathy. And as you can see from this, and you heard in the previous lecture, that the autonomic nervous system supplies all our visceral organs and the sweat glands. So these are the things that I will talk about today, and I will focus on clinical examination only, not so much on the more advanced investigations that can be done for these problems. So we all know that there's a lot of diabetes patients out there, both in India and in Malaysia. In Malaysia, 1 in 5 adults actually suffer from diabetes or pre-diabetes, which is very tragic. It does impact the quality of life, lowers the quality of life, increases risk of death, and of course, it is very expensive to have diabetes. So autonomic neuropathy in diabetes affects the cardiovascular system, the gastrointestinal and urogenital systems, the pseudomotor system. It causes hypoglycemia unawareness and causes abnormal pupillary function. So I will discuss each of these separately. So this is what happens. I'm not going to go into this slide. This is just to tell you these are the things I will be talking about. before I actually dive in, you should know that people with diabetes and autonomic neuropathy actually have a 3 times higher mortality rate, which is something we must realize, because unfortunately most patients who have autonomic neuropathy are completely unaware of it. So it requires a very high level of clinical suspicion when we approach these patients in the outpatient clinic. It's important to know because it is an independent risk factor for heart disease, for stroke, and also for coexisting nephropathy. So cardiovascular autonomic neuropathy, or CAN, prevalence rates are quite high. Patients with type 1 diabetes, it can take up to 20 years for it to affect people, but in type 2 diabetes, where the prevalence rate is about 60%, these actually, the autonomic neuropathy starts even before we diagnose them. So that by the time we have diagnosed them, within 5 to 10 years, they have got autonomic neuropathy. And as I mentioned, they can be asymptomatic or be unaware, which means that we have to detect it. So the risk factors: old age, long diabetes duration, not very well controlled, kidney disease, and other comorbidities like hypertension, dyslipidemia, smoking, and newer risk factors which are coming up now is depression and social determinants of health, which we weren't really aware of before, but which do contribute to autonomic neuropathy in diabetes, and poor control as well. So let's look at the clinical features. The first sign is reduced heart rate variability, which Dr. Jarial had pointed out. Later, they may have fixed rate tachycardia. And this can lead to palpitations, unsteadiness, and syncope because the heart rate doesn't rise with exertion. Okay, it remains the same. As time goes by, there is problems with blood pressure regulation, orthostatic hypotension, and the worrisome cardiac arrhythmias which lead to death. So normally our blood pressure is higher in the mornings and comes down during the night, but unfortunately in people with diabetes and autonomic neuropathy, this is reversed. So these people, they have a fall in blood pressure early in the morning. And this means, and often present with, when they get up in the morning, they feel dizzy. And as the day goes on, they feel better. So this is an important history point that one should consider. Another very, very important problem with diabetic autonomic neuropathy is they have painless ischemia. They don't get visceral pain, which means that they're having a heart attack or an ischemic episode and they are completely unaware of it. So the incidence is quite high in patients with autonomic neuropathy. The Framingham study actually showed that 39% of patients actually had an MI without knowing it when they were screened by ECGs. Obviously, they will not seek help, so the mortality rate is very high compared to those without autonomic neuropathy and ischemic heart disease. Another issue with diabetic patients is that normally most patients have a higher incidence of MI early in the morning. But with diabetic patients, one is they will not get pain, and there they're sitting watching the television after a nice meal and they suddenly feel dizzy or they feel off. They may have nausea, fatigue, confusion, sometimes sweating, palpitations. Actually, these symptoms are so vague that they often put it off to a heavy meal itself, and they don't seek help. They don't go to the doctor until a complication arises. So it's important to look for this, or at least assess the patient before this happens, so that they don't present with a complication. Orthostatic hypotension, as I'm sure you all are aware, is defined as a systolic blood pressure fall of 20 millimeters and or 10 millimeters diastolic fall on standing from lying or sitting position. Obviously, this problem is worse in diabetics because there is no compensatory tachycardia. They have fixed heart rates. So there's damaged vasoconstrictor fibers, impaired baroreceptor function, and of course the cardiac reactivity, as I just mentioned, is poor. So the patient gets up, is able to walk a few steps, and then may suddenly start feeling dizzy, they may have visual blurring, they may have syncope. Before we jump to treating it, we must look for volume depletion, we must look for diarrhea, polyuria, we must make sure they are not on any medications which can cause postural hypotension like beta blockers, alpha blockers, TCAs, phenothiazine. Another issue which we must consider is insulin-induced hypotension. So there are many patients on insulin who tend to have a low blood pressure or a feeling of faintness about 10 to 15 minutes after an insulin injection, and they think it's a hypo coming on, but actually it is the fall in blood pressure which is causing it. The reason why this happens is insulin by itself, even without causing hypoglycemia, causes a fall in blood pressure, but normally the heart rate rises and makes up for it. But in a patient with diabetic cardiovascular autonomic neuropathy, this tachycardia doesn't happen, and so the patient becomes hypotensive after the insulin injection, and this can start about 10 to 20 minutes, and 15 minutes, and it'll last about 20 minutes. So it's important to explain to the patient that maybe they should take their insulin when they're lying down. So what tests can we do in an outpatient to diagnose CAN? Well, the first is a resting heart rate which is more than 100. Okay, this happens a little later. Heart rate variability is the first sign. So what we can do is we ask the patient to take a little walk, say for about 10 minutes, in which they become slightly breathless. They should become breathless. Only then we know that they have, like a diabetic patient may not be able to walk as fast as a normal person, but they should still feel breathless, and then you should check their pulse rate again. So you have checked their resting pulse rate, make them exercise and check it again. And the pulse rate should be about 1.5 times higher. But of course, if they have cardiac denervation, there is no increase in the heart rate, and this results in the patient feeling tired and unable to exercise. Another thing is we describe orthostatic hypotension by saying that the pulse rate should rise by about 30 beats per minute 2 minutes after we stand up or get up from lying down. But this doesn't happen in diabetics with autonomic neuropathy. So how we should measure this is we make the patient lie down for 5 minutes and we check their blood pressure. Then we make them stand up. We watch for 2 minutes. You must not take the blood pressure immediately. We watch for 2 minutes and then we take the blood pressure. A fall of more than 20 millimeters of mercury indicates orthostatic hypotension. Okay, they don't always have a rise in heart rate, unfortunately. So stand close to them, make sure they don't fall. If we have an ECG machine in the outpatient clinic, then we can do this test as well, the beat to beat heart rate variation. When we have a good vagal tone, normally there is tachycardia on inspiration and bradycardia on expiration. This is normal. So it just indicates a good autonomic function basically. But if we take an ECG with deep breathing in a patient with diabetic autonomic neuropathy, you'll find that there is no beat-to-beat heart rate variation. Their RR interval remains the same. It does not change with deep breathing. Okay. Another is the Valsalva maneuver, which Dr. Jarial had pointed out. If we take a deep breath and hold or blow against resistance, normally there is reduction in the blood flow to the heart, and obviously it can cause a fall in BP, but this is counteracted by a rise in pulse rate. But because in CAN there is no rise in pulse rate, there will be a fall in BP. And we can measure this by doing their ECG and finding that there is no change in the heart rate during the Valsalva maneuver. How can we treat CAN? Well, with most means practically all diabetic autonomic neuropathies, the best way is to maintain the blood sugar. So a good blood sugar control is, it not only prevents the occurrence of CAN, but it can also prevent its progression even if it has happened. So this is something we need to focus on whenever we are treating a diabetic patient. We don't want them to develop complications, right? But if they have developed it, high intensity exercise obviously will happen once they are, they can manage the exercise. They should not have syncopal attacks or tiredness because their heart rate is not going to rise. So for these people, they should have gradually increasing levels of activity under supervision. Another thing we can do is beta blockers, because beta blockers will not only reduce the resting tachycardia, but also prevent arrhythmias. How can we treat orthostatic hypotension? First, we try lifestyle measures, of course, because if we use medication, we can, to increase the blood pressure, we can cause lying down hypertension. So that is a big problem. Supine hypertension is an issue whenever we use any measures to increase blood pressure, and therefore non-pharmacological therapy like supportive stockings. Be careful when you're getting up from lying to sitting, wait a little, take some deep breaths, then stand up, stand there before you start walking. So all of these can help. Those who have insulin-induced hypotension, they should take their insulin lying down and only get up about 15 minutes after that. If none of this works, we always have fludrocortisone. That is the standard therapy for orthostatic hypotension. Although it can cause lying hypertension, we also give an increased salt intake, and we try to keep the dose of fludrocortisone as low as possible without causing side effects, because we don't want heart failure. Some studies had shown alpha lipoic acid or even erythropoietin to be helpful, but there's no real FDA approved treatment for CAN, unfortunately. So I've given
Sorry for the inconvenience. There are some network issues going on in Malaysia. We'll be getting back to the session soon. I hope you have patience for that. Thank you so much.
मलेशिया में भी नेटवर्क इशू होता है, so please.
It's a positive quality thing. It's like
Ma'am is not able to share her screen, but her audio will be available and we'll try to share the screen here. Thank you. Ma'am, are we audible? Dr. Madhumita ma'am, are we audible?
Am I audible now?
Yes, ma'am. Yes, ma'am. You can carry on.
Hey.
yes, ma'am.
I'm talking about atony of the large bowel. This can sometimes even lead to megacolon, and that can be quite distressing. Constipation can alternate with diarrhea, and fecal incontinence can happen if there is dental nerve involvement, which causes a lax anal sphincter. Next slide, please. So how can we evaluate? The issue here is that clinically we just evaluate by history taking because there's no definitive examination. But we mustn't jump to the conclusion that anybody who comes with constipation and diabetes has diabetic autonomic neuropathy. Must rule out other causes as well. I am not able to share my screen on my phone, unfortunately, but I am hoping that you will do it.
Ma'am, could you please send the PPT or else through the phone? That could be helpful. Just send the PPT over the phone. We can share the screen here.
Okay, I'll do that.
Yes, thank you, ma'am.
Sending.
Yes, ma'am.
What?
Ma'am, you can continue. Ma'am, you can just continue. It's all right. We can. You are audible, so please continue, ma'am. Ma'am, can you unmute yourself? We are not able to hear you.
Yes, yes, ma'am.
Hello.
Ma'am, continue your talk. We are able to hear you now.
Okay, right. I'm so sorry about this. As I was saying, before we decide that the patient's constipation is due to diabetic autonomic neuropathy, we must rule out other causes, certain drugs, hypothyroidism, which can occur at the same time, and of course, please rule out colon carcinoma because of the age group. So, all patients with constipation must have a digital rectal examination. Women must have a vaginal examination as well. And stool specimens should be tested for blood and occult blood. Next slide, please. If a patient has constipation, again, lifestyle measures are the safest. We say drink lots of water, exercise regularly, have food with high fiber. If that doesn't work, then we can try sorbitol or lactulose. Sometimes enemas may even be required. So yeah, just lifestyle measures are the safest. Now and then we can use other measures. Okay. How about gastroparesis? Now, this is a very, very uncomfortable problem that some patients with diabetic autonomic neuropathy face. Gastroparesis diabeticorum is about 25% prevalence in the diabetic population. And these people will tell you, doctor, I feel hungry, but when I eat, I'm sorry, I just get full so fast. I just can't eat anymore. And then after a couple of hours, they may even have vomiting. They have bloating and nausea. It's a very distressing symptoms for them. Next slide, please. A classic feature of gastroparesis is erratic blood sugar levels. They often have hypoglycemia after meals. And they think it is probably because they've taken too much insulin or they've taken their medication. Maybe they need to reduce their medication. So they might even skip their medications and they will say, doctor, I was getting really low blood sugars. And this should warn you that this patient probably has gastroparesis. And take a good history. If they have erratic blood sugar control, they feel full and bloated after meals and even just eating a little bit, and sometimes they may vomit food they took yesterday. So then we can know that this is probably gastroparesis diabeticorum. But again, just like with constipation, always rule out other causes of gastroparesis or of the similar symptoms. Next slide, please. There's unfortunately no simple clinical test which can prove it. Has to be done in a laboratory. So we depend in the clinical setting on history taking basically, and follow it up with maybe a 24-hour glucose monitoring, which will show that they get post-meal hypoglycemia. If they are on GLP-1 receptor agonists, it's a good idea to stop it. Gastroparesis and GLP-1 RAs don't mix. Sometimes they may have gastroparesis without symptoms. We may not treat them unless they are vomiting. Next slide, please. How can we treat it? In the outpatient clinic, actually, we can treat it simply by, again, lifestyle measures first. So let's look at the lifestyle measures that can be used. First, try not to give them very high fiber meals or high fat. You can reduce the stomach emptying anyway. Greasy foods, carbonated beverages can always make it worse. Sorry, previous slide. and previous, before this. No. The next one, I need the previous one, before this even. So what I want to tell you is that patients with gastroparesis should have light proteins, cooked vegetables. They should not eat high fiber foods. Okay, so this is the important thing that I wanted to focus on. Okay, next slide, please. If lifestyle measures don't work, then we can use prokinetic agents. So prokinetic agents, metoclopramide, domperidone, levosaccharide, erythromycin or azithromycin, any of these can be used. Even two of them can be used, like metoclopramide and azithromycin, but for all of them, they should only be used intermittently. We cannot give them long-term. Metoclopramide, as you know, can cause extrapyramidal effects, and antibiotics, obviously, we can't give long-term, so we give them intermittently. If it works, so if not, we can try other measures. If we are opting for surgical intervention, radiography before that. Gastric electric stimulation, jejunostomy, and gastrojejunostomy done. Gastrojejunostomy, of course, permanent. Jejunostomy is temporary. Next slide, please. Okay, the next problem is diabetic diarrhea. Diabetic diarrhea is also fairly common, and the classic history is that they will complain that they have to go to as soon as they finish eating. So this is their first complaint. Doctor, I don't know why, but I have to go to the toilet. Some of them will also need to go to the toilet in the middle of the night. Nocturnal diarrhea is another problem. Sometimes this diarrhea can be quite severe. They may have to go to the toilet 20, 30 times a day. But these cycles of diarrhea often go away and they have good periods and then it comes back again. Fecal incontinence can also. Oh, next slide, please. So, how do we evaluate it? Again, there is no definitive test. It is in clinical practice. So, it's all based on history. And obviously, we must rule out other causes. There are drugs like metformin, acarbose, some sweeteners that people may use, which can also cause diarrhea. Because there is spinal dysmotility, initially there may be atony, then there might be hypermotility. So, bacterial overgrowth can occur, pancreatic insufficiency and steatorrhea may be a problem, and bile salt malabsorption often. Slide, please. If we are treating diabetic diarrhea, initially, if they are dehydrated, we must correct that first. Good, like all problems of autonomic neuropathy, good glucose control is first and foremost. All autonomic neuropathy have good glucose control, can its progression and even control it. Antidiarrheal agents can be tried when there is a large number of stools, or if they're going out, they will often say, I have to travel, can you give me something? So you can use loperamide. But please be careful because toxic megacolon is a big. Next slide, please. To treat the bacterial overgrowth, we can give doxycycline or metronidazole. Usually we give it for 10 to 14 days only. We can cycles. Bile salt chelation can be done with cholestyramine, sometimes that. Clonidine actually helps with severe diarrhea, but unfortunately we need dose. Again, it's short term. And the last option is always octreotide. Next slide, please. Esophageal dysfunction, fortunately, is not very common in diabetes. They may have GERD, and if they have gastroparesis, they may have some amount can worsen the GERD as well. If they have GERD, to really diagnose esophageal dysfunction, again, we need endoscopy, motility tests, and scintigraphy, which is not done in the outpatient. Next slide, please. Moving on to the genitourinary tract. Okay, genitourinary tract problem incidence is very high, especially threefold increase where women, it's a 50%, 1.5 times. The reason may be because we don't check for sexual dysfunction in females that much. First, in history taking, we must ask for lower urinary tract symptoms. So these can be storage problems, which can cause urgency, frequency, incontinence, problems, straining, and the men may have these problems even without prostate. Must look for post-micturition dribble or incomplete emptying is extremely common. Erectile dysfunction has of being a harbinger of cardiovascular disease. So if a patient has erectile, we also have cardiovascular. Next slide, please. So when we examine a patient with diabetes, of examining the abdomen, we find that the bladder is really huge and the patient is completely unaware. This is because there is no pain. The visceral sensation is gone, and so the bladder really becomes big, and even when we press it, it doesn't cause any discomfort. So because the patient is not uncomfortable, they will not even a dangerous situation because obviously cause infection. Next slide, please. If we have an ultrasound in the clinic, we can do an ultrasound, a bedside ultrasound, and a residual volume of more than 150 ml. They have, and there's an increased risk of infection. So the different types of infection. Where in women, they often have urgency and overactive bladder syndrome, unlike in men. Next slide, please. How do we manage cystopathy? Well, first of all, we have to make the patient aware that, look, here's your bladder, can you? And we make them actually put, and then we show them where the bladder is, so that they know that this is a full bladder. Then we tell them to go to the toilet and press down just above the pubic bone, and that helps them to pass the urine. And we tell them to palpate themselves every 4 hours, and when they feel that the bladder is enlarged, they must go and empty it out. Sometimes double voiding helps. They press, pass, and then wait a little, and then do it again. That's of infection. If all this doesn't work, then we go for bethanyl or sphincter relaxant. Last resort is self-catheterization. Tell them to catheterize themselves once before bedtime and once sometime during. Catheterization usually has a low risk of infection. Next slide, please. So, erectile dysfunction is a huge problem. Half the men with diabetes complain of erectile dysfunction sometime during their diabetes. Actually, type 2 diabetes within 10 years of diagnosis. With women, limitation is that they don't come to you with problems anyway. But there is about a 30% incidence, according to present statistics. So what happens in men? There is loss of erection, there may be retrograde ejaculation, but it does not affect libido and orgasmic function. So it's very distressing for the man because although they have the libido, they are not able to get the erection. And so they will tell you directly, doctor, I'm having a problem. Um, Erectile dysfunction can be due to neuropathy, but remember that they all vascular supply that can contribute to the erectile dysfunction, poor control of their blood sugar, nutritional deficiencies, and most importantly, drugs which are used in the treatment of complications, antihypertensives. These cause erectile dysfunction as well. I'll go into the list a little later. Next slide, please. So the first things that happen is decreased rigidity, and they lose their nocturnal tumescence and morning erections. And this gradually progresses. Please remember, because of rather than autonomic. And as I mentioned before, erectile dysfunction marker for cardiovascular disease. Slide, please. How do we evaluate it? In the outpatient clinic, we take a very good history. We ask about nocturnal tumescence, morning erections. We do a psychological, physical evaluation, including looking for anal tone. Blood pressure, dyslipidemia, blood sugar control is looked at. Also, do all the tests for cardiovascular autonomic neuropathy and peripheral vascular supply, and we review the medication. This is a huge list of medications which can cause erectile dysfunction, and if they can be changed, we try to change them. If we can't, then we can't. Well, do. Next slide, please. So this is the list of drugs which cause erectile dysfunction. When we examine the patient, we should also, as I said, look for any other neuropathy. Loss of ankle jerk, reduction of vibration sense, loss of perianal sphincter tone and perianal sensation should also be looked at. The bulbocavernosus reflex, that is transvenous contraction of the sphincter, is another indicator for erectile or autonomic neuropathy, peripheral neuropathies. Next slide, please. So treating it, first, they should stop smoking, should stop alcohol, they should have good glucose control. These, without saying, smoking and diabetes absolutely do not go together. If lifestyle measures and a change in the medication perhaps doesn't help, sildenafil. Sildenafil is very useful, but obviously in patients who are on night. If we cannot give sildenafil, we can try direct injection of prostacyclin. The man is taught how to do this. Or there are penile prostheses. When they need it, they fill it up, and when it's not required, they can. That is all we can do for erectile dysfunction. Next. So female sexual dysfunction, well, there's no established guidelines. So we need to ask the woman, do you have any problems? Because they will not usually tell you about it. Dyspareunia, inadequate lubrication, vaginal laxity. Funnily enough, in women, sexual arousal or desire is also decreased. That is a tragedy because men, the libido doesn't decrease really. So we try vaginal lubricants, estrogen creams, and nowadays there's some studies being done on transdermal sildenafil. Oral sildenafil can also be given to women, obviously they're not on nitrates. Next slide, please. Pseudomotor dysfunction. So pseudomotor obviously is sweat gland activity. Now, we sweat when hot, of course, but we also sweat when we are stressed. So when we are having a heart attack or when we are very nervous, that's a cold sweat, right? But that is also disruptive. And both sweating mechanisms are involved in autonomic neuropathy. So we do doesn't get sweating. Next slide, please. One characteristic feature of diabetic autonomic neuropathy is that the upper body sweats more. So if they are eating something spicy or if it's a hot room, their face will be red and sweaty, but their feet are cold and dry. Why this happens is not known, but fortunate truth. And the skin being dry means there is cracks. Cracks can lead to infection and gangrene. That's what is one of the major complications of diabetes. Next slide, please. How do we assess? Actually, again, there is no definitive clinical assessment for the dysfunction. The only confirmatory test, skin biopsy, which we don't go for on a general basis. We try lifestyle measures and other measures first. So what we do is we look at the feet, we look between the toes, we look for cracks, ankle reflex testing, vibration sense testing, Semmes-Weinstein touch test. Another one which tells you that circulation is poor is the foot raising test. So when we put the foot down, if there is autonomic neuropathy, the foot becomes red, and when we raise it up, it becomes pale. This indicates that there is autonomic neuropathy, allowing the blood vessels to constrict when required. Ankle brachial index for peripheral vasculitis. So an important. Next slide, please. How can we treat it? Well, hyperhidrosis of the face and chest, just avoid spicy food, try to figure out them. If that doesn't work, glycopyrrolate. Very, very important for patients with dry feet and dry leg skin is they must use skin emollients, they must inspect their feet, and sugar control and think progression. Awareness. Next slide, please. Okay, so this is another very important side effect of autonomic neuropathy. The patient with diabetes often becomes unaware that they are having a hypoglycemic episode, and even the body responses to hypoglycemia. So normally, when there is low blood sugar, catecholamine release happens. This produces the features of the autonomic, which is trembling, cold, feeling of hunger, and so the patient is immediately aware, yes, they're having a hypoglycemic episode, they will quickly eat. Next slide, please. So autonomic, next slide. Autonomic symptoms are a warning sign. Next slide, please. Yeah, autonomic symptoms are an important warning of hypoglycemia. No, before this. Slide before, please. Yeah, autonomic signs are a warning sign. The next thing that happens when the blood sugar falls below 2 is what is called neuroglycopenic syndrome. Here, the patient will become confused, they'll become dizzy, they won't be able to pick up, they will not be able to help themselves. Neuroglycopenic features means somebody else has to come and help them, or they slip into coma. So this is what we don't want. Next slide, please. Apart from the symptoms that happen with hypoglycemia, the body has a normal hypoglycemic response. So whenever there is hypoglycemia, of course, epinephrine is released and glucagon is released. Glucagon makes the liver release the glucose, there's glycogenolysis, gluconeogenesis as well. And so these are the counter-regulatory mechanisms. There is also growth hormone and cortisol in the longer term, which keeps the blood sugar normal. Unfortunately, long-term diabetes, which leads to neuropathy, autonomic neuropathy, these features of response of the body to hypoglycemia is gone. And so even though there hypoglycemia, the blood sugar doesn't rise for these people either. So they can quickly slip into coma. Next slide. How do we treat hypoglycemia? Next slide. Next slide, please. Thank you. How do we treat hypoglycemia? Unawareness. Now, hypoglycemia, unawareness, and unresponsive. Sorry, previous slide. Yeah. It's only autonomic neuropathy where we don't control the blood sugar too much. For every other complication, we like to keep the blood sugar well under control. But here, we need to keep the blood sugar a little high because we don't want them to become brain damaged. So we try to keep the HbA1c between 7 and 8, closer to 8 rather than 7. Fasting blood sugar also, we try to keep it around 8, 7. Hypoglycemia is seriously dangerous for the patient. Next slide, please. Okay, the last thing is pupillary abnormalities. Pupillary abnormalities, next slide, happen in diabetes with autonomic neuropathy. Next slide, please. Okay, so whenever there is diabetic autonomic neuropathy, one of the first things that happen is pupillary abnormalities. They have what is called an Argyll-Robertson type. We don't call it ARP because ARP is named as a pupillary sign for syphilis. So we don't call it ARP, but we say AR like pupil. Light reflex doesn't constrict the pupil, but accommodative reflex is present. Diabetic persons with autonomic neuropathy actually have smaller pupils anyway. And so they will say, doctor, I don't see very well at night. Vision. They think that they are developing cataracts or retinopathy, but check the pupillary reflex and that is what we see. The small pupils. So again, the treatment is strict blood sugar control. Next slide is the last slide. Just a revision of, next slide please, of all the medications that we can use. Next slide please. Next slide.
नाही विचारलं मी निलेशला नाही उल्हास पाटलांचा काही संबंध नाही.
This is the last.
त्यांचा काही संबंध नाही.
And thank you so much. I'm very sorry about the glitch because electricity suddenly went off here. Any questions for me?
Yeah, Dr. Sen, that was, thank you for a very exhaustive, multi-disciplinary approach to diabetic neuropathy. Any questions? from the audience? Yeah, please.
If you want to put it in the WhatsApp group, I can answer because I may not be able to hear you very well.
Hello, Dr. Madhumita. Can you hear me?
Yes, I can hear you.
Firstly, that was a really good lecture. It was very, very comprehensive. So thank you for that. I just wanted to bring out one point, I guess. While you did mention that hyperglycemia has an increased risk of causing diabetic autonomic neuropathy, and that's why the ADA recommends that we have intensive glycemic targets, keeping the HbA1c less than 7. What has also been found is, I just wanted to add that point, what has also been found is that as per the ACCORD trial, hypoglycemia also is an independent risk factor for diabetic autonomic neuropathy and cardiovascular autonomic neuropathy. In fact, what has been found was that hypoglycemia leads to recurrent hypoglycemia, which causes lack of hypoglycemic awareness, and that causes autonomic failure. So while intensive glycemic control is recommended, there is a greater risk that if you have hypoglycemia, you're more likely to also develop autonomic failure. So that was
Correct. Yeah,
that was one point. I think the second thing that I wanted to bring up is that there have been multiple trials regarding newer drugs like SGLT2 inhibitors and GLP-1 receptor agonists, and their role in essentially preventing diabetic autonomic neuropathy, but there's no real concrete evidence. Could you comment a little more on that?
See, these newer drugs help with prevention of complications like cardiovascular, but they have not been really tried out to prevent autonomic neuropathy. It has been seen that whenever you keep the blood sugar well under control, that means between 6 and 7 fasting and 7 and 8 post-meal, autonomic neuropathy the progression is reduced. It progresses less. In fact, it prevents also. It has been seen that it prevents the occurrence of diabetic neuropathy. But whether it can actually prevent diabetic neuropathy by itself, there's not been any studies on that. At least I haven't seen any studies on this.
I have seen a few studies, but any of the randomized clinical trials that have actually happened, and even meta-analysis, they've essentially said that we need more data. So I think maybe it might be very, very early days to essentially comment on it.
Sorry, I couldn't make out. Can you say that again?
While there have been studies that have shown some benefit, there have been certain RCTs, randomized controlled trials, and meta-analyses that have been conducted, and they say that there's still more evidence required to essentially say whether there is an effect or not. So I think I think we're 10 years away from that point.
Because, when we are controlling sugar, it is not progressing. That is known already. Now, whether it is not progressing because of the drug itself or because it's controlling the sugar, we haven't separated that out yet. So it's hard to answer the question directly by saying that, yes, GLP-1 RA or SGLT2 inhibitors actually prevent autonomic neuropathy unrelated to the blood sugar. So we don't know that.
Thank you so much for that.
Madam, one question. One question, madam.
Yes.
सबके पसंद के लिए diabetic autonomic neuropathy. Diabetic autonomic neuropathy. Which factor is more important?
Yes.
It is the degree of control or the duration of diabetes? आपका अपना experience क्या कहता है?
Okay, now when we say longer duration of diabetes, it also means uncontrolled diabetes. if the diabetes is very well controlled, they may not develop autonomic neuropathy. But the problem with type 2 diabetes is very often we actually diagnose the diabetes a good decade after the pre-diabetic, the damage has already stopped. Which is why when a lot of patients come and we diagnose them with type 2 diabetes, they've already developed retinopathy, sometimes nephropathy, peripheral neuropathy. So some damage has already been done. But in type 1 patients, it has been seen that nowadays with CGM, with continuous glucose monitoring and with artificial pancreas and all that, we have seen that we can delay the onset of diabetic neuropathy. So what this means is that it is the control which is more important. The duration is only because the problem is that yes, longer duration means more up and down in blood sugar. But this is really my personal opinion. I haven't done a lot of studies on this, but according to studies, good control means better outcomes.
Okay, I think we'll wind up here. Thanks, Dr. Sen, for opening the eyes to the major problem with diabetes. I will not say much, except clinicians are at great fault for ignoring autonomic nervous system, implicating or causing a lot of damage to the body in many, many ways, in many, many diseases. The prime example is, of course, diabetes, and that's very unfortunate. If I were to say one awareness, I'm thankful to department. I think autonomic nervous system should be taught more and more exhaustively, and clinicians should be made aware of this very, very important system in the body. The one faculty I know which kinds of looks at autonomic nervous system are the anesthetists, if they look at it. And that too during the operation. But हम clinicians fail हो गए हैं. And I thank you for having this seminar. This is wonderful. Thanks all of you, and thank you, Dr. Sen.
Thank you for having me.
Thank you, ma'am. We are grateful that you could make a time and give your precious time. I'm sure that you were busy with your clinics, and Department of Physiology and MTMC thanks you for accepting our invitation, ma'am. Thank you once again.
Thank you.
Okay, ma'am. It is our privilege to acknowledge and felicitate our esteemed moderator, Dr. Sunil Nandwani, who's a senior consultant physician at Mercy Hospital, Jamshedpur. So I request Dr. Suhas Tetarve, Professor and Head of the Department, LCMCH Palamu, to felicitate the moderator, Dr. Sunil Nandwani. Dr. Suhas sir, if I've mispronounced your name, I'm sorry. A round of applause, please. Yeah. All right, sir. Thank you once again. And we are now come to the ending of the first session of Scientific. Now we'll go for the cafeteria for having a lunch. We'll be back exactly at 2 o'clock for the second session. There are 2 more interesting sessions. Exactly 2 o'clock, we request you all to be back so that, we can continue our enriching sessions. Thank you once again. Thank you all.
It is my distinct honor and privilege to introduce to you our esteemed speaker for today's session, Dr. Shival Srivastav. Dr. Srivastav is a distinguished academician and a clinician currently serving as Associate Professor of Physiology at AIIMS, Jodhpur. He holds an MD in Physiology from AIIMS, New Delhi, along with a DNB in Physiology, and is a member of the National Academy of Medical Sciences. His academic contributions are both very vast and impactful. He has authored 34 publications in peer-reviewed journals, 4 book chapters, and 1 book. With over 430 citations and H index of 6. His primary area of interest lies in autonomic and vascular function assessment, a field in which he has demonstrated exceptional expertise. At AIIMS Jodhpur, Dr. Srivastav plays a pivotal role in running the Autonomic Function Laboratory, catering to an annual patient load of over 700 individuals. He has personally supervised autonomic function testing in more than 3,000 patients till date. Yes. It is a commendable one. His technical proficiency extends to digital data acquisition systems such as Biopac MP50 and PowerLab, with specializations in HRV, BRS, and BPV analysis. Dr. Srivastav is also an accomplished educator and a very good speaker. He has been an invited expert at 16 conferences and symposia, a resource person at 11 national workshops, and even represented at 2 SARC level workshop on autonomic function testing. His numerous accolades include the Srimati Shubha Mukherjee Memorial Oration Award by the Physiological Society of India 2024, Professor N.S. Dalal Award for Best Poster in Basic Science by the Indian Society for Heart Research. He has also earned awards for oral and poster presentation at national conferences such as SOPCon and NIMANS. Beyond his academic and clinical excellence, Dr. Srivastav is a passionate collector of fountain pens, yes, enjoys exploring new coffee flavors, and has a keen interest in the evolving landscape of tech news. So please join with me. Please give him a very big round of applause. And I now request Dr. Shilpa to introduce the moderator for the session. So welcome.
Once again, good afternoon. I now kindly request Dr. Gauri, Professor and Head of the Department of Physiology of MGM Medical College, Jamshedpur, to moderate a session on quantifying diabetic autonomic neuropathy in the physiology laboratory, insights into HRV and Ewing's battery of test by Dr. Shival sir. Sir, over to you.
Before I start, in the morning in the workshop session, there were a lot of questions regarding the non-availability of equipment. We have ideas available to us for doing research, but unfortunately the equipment that you need is not available to you as of now. So what can be done about it? So to bring into this issue, I would like to highlight a program that is being run by the Association of Physiologists and Pharmacologists of India, APPI. APPI has launched an equipment grant in collaboration with AD Instruments, and the details are available on the website. Just give me a second, I'll show you the website. Just give me a second, I'll share my screen. So if you go on the APPI website, appi.org.in, and if you go into the notices space, so in the notice you will see the second notice that is available, APPI ADI equipment grant. Once you click on this notice, a PDF will open. So therein the detailed terms and conditions are given. This call was closed recently, but it will be opening soon. So all the people sitting in this room who need equipment for research, I would request you to please go through this notification. Under this equipment grant, Association of Physiologists and Pharmacologists of India has collaborated with AD Instruments, and they are giving out 10 equipments, 10 power lab systems with necessary transducers for the purpose of research for a period of 1 year. This equipment and the transducer that are necessary will be given free of cost at no cost to the researchers. But for that, the requirement is that you have to submit a project to the Association of Physiologists and Pharmacologists of India that will be screened by a scientific committee. So this call closed recently, but many equipments are still available and this will be opening soon. So I request all of you to please go to appi.org.in. Go into the notices section where you can get hold of this document, the equipment grant, and you can go in details regarding the terms and conditions. And if equipment is a limitation for your research, that you have an idea but equipment is not available, the association will provide it to you free of cost for a period of 1 year. So with this, I would like to start my session. Screen share कर दिएगा. So the topic I have chosen is to quantify diabetic autonomic neuropathy, or if I may say cardiac autonomic neuropathy, in patients with diabetes using the heart rate variability and Ewing's battery of tests. So in this talk, I will first go with the following outline. What is cardiac autonomic neuropathy in context of diabetes mellitus? Why should we as a physiologist or a clinician worry about cardiac autonomic neuropathy? Then how you can evaluate cardiac autonomic neuropathy in the clinical physiology lab using heart rate variability and Ewing's battery of tests. A bit about scoring CAN, how you can grade CAN. This was partly covered in the workshop in the forenoon session. And then we'll briefly show some of the works in this area. So lot has been said about diabetes. Diabetes is a ticking time bomb in the context of India. India will soon be, if I may say, having the dubious distinction of diabetes capital of the world. And in ICMR India study, which was published in 2023 recently, we can see that the prevalence of diabetes is quite high in India, and in some states it is going more than 10%. So there is a lot of prevalence and morbidity because of diabetes, and this is a problem of a national magnitude and a global magnitude that merits attention. So in this context, we like to see autonomic neuropathy. So again in the morning, sir had discussed about, and madam also talked briefly about autonomic neuropathy. So it is because of the pathological processes that may take place in the central nervous system or in the peripheral part of this nervous system. And these processes include, but these are not limited to, degenerative changes, mass lesions, infections, seizures, strokes, etc. Diabetes, in this spectrum, diabetes is primarily causing a degenerative change in the autonomic neurons, and this is manifesting as autonomic neuropathy. The symptoms, I'll just touch upon them briefly. They were covered in detail by ma'am. So they include resting tachycardia, orthostatic hypotension, urinary issues. Then patients may have dry eye, blurred vision, constipation, GI disturbances may be a problem. Cognitive challenges, vascular manifestations such as Raynaud phenomena and heat intolerance may also be seen. Most of the symptoms in autonomic neuropathy are non-specific or atypical, and as sir said in the morning, this is the reason why autonomic neuropathy is not detected early. Because the symptoms are non-specific, patient may not take note of it, or even if he or she is having these issues, they may not be attributable to a specific cause of autonomic neuropathy. And as a clinical physiologist, we should be aware of these symptoms, and then screening or some measurement should be instituted. Interestingly, if you take a careful history, many of these symptoms have aggravating factors. So aggravating factors of autonomic symptoms consist of heavy meals, that is the patient may have postprandial dizziness or postprandial discomfort. Then some drugs may precipitate or may worsen autonomic neuropathy symptoms. Alcohol, symptoms may be worse early in the morning. After exercise, exercise intolerance is a common symptom for autonomic neuropathy. Also, there may be worsened by fever and very often so by dehydration. From the part of country where I am working, Jodhpur is a dry state in the sense that the air there has a low moisture content and people lose a lot of water. So many of the patients that are coming to us in I may say the symptom of syncope or orthostatic dizziness is very high because of any imbalance in the water intake coupled with dry air and lack of water intake will precipitate or aggravate the symptoms. So a careful history can help you clues regarding autonomic neuropathy, and we should take careful note of these symptoms before evaluating the patient. Then CAN, if we go on to define CAN is the neuropathy of the autonomic nervous system seen in patients of diabetes mellitus and after exclusion of other causes that may affect the ANS. So diabetes mellitus can manifest as autonomic symptoms, and this constitutes the picture of CAN. And what I would like to discuss in my talk is that why should we be cautious or worried about CAN, what is so clinically important, when to look for CAN and how to look for CAN. So CAN, the pathophysiology of CAN in diabetes mellitus is very complex. The major culprit here is hyperglycemia. Hyperglycemia leads to a lot of metabolic pathways, activation, polyol pathway, advanced glycosylation end product that some of the UG students may have read in their textbooks, polyol pathway, etc. And all of this with the pro-inflammatory milieu lead to the neuronal injury. Since the vagus nerve or the parasympathetic system has a very large distribution and the neurons are very large, spread large over the body, probably this is one of the reasons why they get affected earlier, and parasympathetic involvement is seen early in the course of diabetes mellitus. One of the earlier symptoms is parasympathetic loss. Now, when to look for CAN? When should we take a patient of diabetes for CAN assessment? So two guidelines or two recommendations are there. One important Toronto consensus, there was a CAN subcommittee panel in 2011. They decided upon the different literature and the information available, and they recommended, based on the literature review and other criteria, that in asymptomatic patients of type 2 diabetes mellitus, right at the time of diagnosis, and in patients of type 1 diabetes mellitus 5 years after the clinical diagnosis of disease, screening for CAN should be instituted. So if you see a patient of type 2 diabetes mellitus right at the OPD level when the patient is visiting and is clinically confirmed, he or she should be screened for CAN. In type 1 diabetes mellitus, we can have a window of up to 5 years, but after that screening should be done, and we should make an attempt to document the nature and the severity of CAN. Then the second part is, okay, we have documented once, what ahead? After the documentation or the quantification of CAN, annual screening should be done for the assessment of autonomic neuropathy. These guidelines come from American Diabetes Association. In 2025, they published a comprehensive review of many conditions in diabetes: retinopathy, nephropathy, neuropathy. So in the neuropathy section, they clearly, verbatim, they write is that all the individuals with type 1 diabetes and type 2 diabetes, they should be screened for CAN. And after a diagnosis of cardiac autonomic neuropathy has been made, annual screening should continue. Patient should be screened and measurement should be done annually and documentation should be done. Now, the CAN, cardiac autonomic neuropathy, is important because the manifestations that can be there because of this underlying neuropathy are very severe. As again said in the morning, the earlier symptoms are very, I may say, subtle. They have impaired HRV, which is seen in the subclinical stage. Since HRV is not done as a routine measure in the part of the clinics, so the subclinical stage is often missed. Then in early part of diabetic autonomic neuropathy, the symptoms are very simple and very innocuous, such as resting tachycardia, which may or may not be noticed by the patient, and exercise intolerance, which can be attributed to n number of causes. Then only when CAN has progressed to a severe degree and has affected both the limbs of the autonomic nervous system, patients manifest clinically and they land up in orthostatic hypotension with episodes of syncope, blackouts. They may have arrhythmias, and some of them may even land up in myocardial infarction. So our role comes in the setting of the staging between the subclinical and the early CAN. If right in the time of the diagnosis, or in cases say patients who are in pre-diabetes, CAN assessment is instituted, we can diagnose cardiac autonomic neuropathy right in the early stages and probably institute some treatment, better glycemic control, then exercise prescription, lifestyle modifications, etc. to prevent cardiac autonomic neuropathy progressing into an advanced stage. Now, a lot of data or recommendations are available. These are some of the studies I came across repeatedly while reading about this. Two trials, the Accord trial in 2010 and EDIC trial in 2013. Both of them place an emphasis on the importance of cardiac autonomic neuropathy and diabetes. So in the Toronto Committee Subconsensus panel, they have graded the evidence based upon the literature available, and they have repeatedly referred to these two studies, and they say that patients with baseline CAN are almost twice as likely to die as patient without CAN. The risk is almost 2 times, and in the EDIC trial, they said that it has the myocardial involvement, concentric remodeling is seen, heart involvement may be there, and it is independent of age, gender and other factors. So again, this re-emphasizes, or I may say places more importance into the need for CAN assessment. Now, CAN in the physiology laboratory fortunately can be assessed very easily. There are 2 key parameters that are used in many of the laboratories, which are heart rate variability and Ewing's battery of tests. These parameters are easy to perform. They are patient friendly, non-invasive, so it is easy to do, as you may have seen in the morning. Then they require simple tools. With practice, they are easy to master and can be instituted in case of the OPD settings or even in the bedside settings. And multiple tools are available for the assessment of CAN and for the analysis of data. So using a battery of these 2 tests, the heart rate variability and Ewing's battery of tests, cardiac autonomic neuropathy screening can be done. As per the recent guidelines that were proposed, now they have also added for QSAT, quantitative pseudomotor axon reflex testing, for the purpose of small fiber pseudomotor involvement. And they also recommend that beat to beat blood pressure is a baseline requirement. But even if your institute does not have these 2 techniques, QSAT and beat to beat measurement, we can start with these 2 parameters that are available. So before we begin the assessment of heart rate variability, there are some, I may say, confounders or some factors you should be aware of which can affect your recording. So they can be clubbed into patient factors, environmental factors and equipment factors. So let us go briefly through them one by one. HRV, or the autonomic function test, along with the HRV and reactivity, they are affected by gender, age, then tobacco, coffee and tea and other substance containing psychoactive alkaloids. The meal, they can affect the autonomic measures, and they can also be affected by exercise. So for the purpose of ANS evaluation, the specific instructions that are given to the patient are to avoid tea, coffee on the morning of the test, then report to the lab 2 hours after a light meal, avoid heavy physical and strenuous activity in the last 24 hours, and before the test, we request the patient to empty the bladder and provide a supine rest of 5 to 10 minutes to help the patient attain the baseline parameters. Then again, as per the new guidelines, instead of the cutoff values, now the entire diagnostic criteria is based on percentiles. So age appropriate data should be collected in the lab because these can be affected by age and gender and other factors. An appropriate percentile measure should be instituted before referring to tests as normal or abnormal. Then environment factors can also have a bearing on the autonomic measure. That is why it is recommended to do the test in a noise-free, temperature and humidity controlled environment. It is recommended that supine posture should be used for most of the tests, except for Valsalva and deep breathing, they can be done in sitting posture. Then late evening recordings should be avoided, preferably done in the forenoon, or if the patient is coming in the afternoon, ask the patient to have a light meal, not a very heavy meal. Then for research studies, if you are pursuing these parameters from a research design, we should be consistent with the timings. All the recordings should be done in a forenoon or afternoon time period only, because the time of the day may affect these parameters. Then for getting good data, there are some equipment factors that also should be kept in mind. So equipment factors, the equipment should have a good sampling rate. You should classify and delineate the variables of interest that you want to record. For this evaluation, we require the lead to ECG signal, the respiratory movements, and if it is desirable to have beat to beat blood pressure measurement, then the software tool which you are going to use and the parameters that you plan to assess, all these should be taken care of. Fortunately, because of the advancement of technology, lot of data acquisition systems are available. These are some of the popular data acquisition systems that are available. They have a very high sampling rate. They have ability to reject unwanted signal. Noise rejection is good. Signal to noise ratio is very good. Then they are portable. The software with successive iterations has become more and more user friendly, and they have a lot of computational abilities that are available. So I'll just demystify some of the terms that you come across in the data acquisition part. First is the sampling rate. So imagine there is a fan running in the ceiling and I'm trying to make a video of the fan using a DSLR or using a camera. So to have a smooth video, I need a certain set of images, at least 8 to 9 images per second, so that these images, when taken in succession and are run, they translate into a smooth video. So sampling rate of the equipment is, I may say, roughly or similar to the number of samples that are captured by the instrument per unit time. So to acquire reliable high fidelity data, we need good sampling rate. For electrocardiogram, the recommended sampling rate is at least 128 samples per second. Again, with the advancement of technology, now the minimum sampling rate or the baseline sampling rate in most of the equipment is 1000 samples per second, 1 kilohertz or better, and they can even go to 10 kilohertz. So sampling rate is not a limitation, but we should be aware that we should have a watch at the sampling rate when acquiring the data. The other common parameter or common term that you may come across is a filter that should be used. So to take into common parlance, the filter can be understood by the simple example of pouring tea into a teacup using a sieve. So the filter will help you capture the signal of interest, at the same time rejecting unwanted signal. So if I want to have no tea particles or no tea leaves in my tea, I need to have a pore size to be very small, so that only liquid part is filtered and the particles are kept in the sieve itself. Similarly, filter also allows you to define the limits of what voltage you want to acquire, what frequencies, and then reject the unwanted frequencies. So in our setup, 50 Hertz frequency is very common. It is because of the AC current in the power line that are there in all the places. So 50 Hertz needs to be rejected, and based upon the requirement. For example, in the morning I showed you that for electrocardiogram, the recommended filter is a band pass filter. A band is defined where the upper cutoff is 35 and lower cutoff is 0.5 Hertz. And anything below 0.5 and more than 35 is rejected, and a good ECG signal can be acquired. So a good filter needs to be found out for the signal of interest, and same has to be applied before the recording. What does the data acquisition system do behind the scenes is that imagine the electrical activity, the electrocardiogram going on in real time, leading to the contraction of the heart. If I want to record this electrical activity, the first I need to capture this data or sample this data by some means. So what I do is I attach the electrodes on the body, connect it to an amplifier which will increase the magnitude of the signal, make it recordable. Then after amplification, some filtering is required, and then the data can be recorded and stored. Again, all these requirements are inbuilt or met with the data acquisition systems present today, and these features have already been shown. Now, starting with the two parameters, heart rate variability and Ewing's battery of tests. So a common adage that you may come across in research papers and textbooks is that heart is not a metronome. Heartbeat fluctuates on a beat-to-beat basis, and quantification of this variability in the interbeat interval or the RR interval is known as heart rate variability. So we use measures of dispersion and other mathematical techniques to quantify the indices of HRV. The common window that is recommended for heart rate variability is a minimum of 5 minutes. If Holter recording is available at your setup, 24-hour recording is also possible. So again, as shown, the systems allow us to capture the signal and derive in real time parameters such as heart rate and RR intervals. So we can see that heart rate is varying on a beat to beat basis, and same goes for RR interval. Now, how much is this variation is quantified by means of heart rate variability? Now, we'll try to look into the parameters. So, this is all because of the efforts of Professor Solange Axelrod. She was a particle physicist actually at MIT, and she was working with Richard Cohen at this time, and they were into signal analysis, and they found out they proposed the frequency domain or spectral analysis of HRV, and based on that the heart rate variability analysis is defined into time domain and frequency domain parameters. So these are some of the common parameters in time domain and frequency domain and non-linear measures. Now let us try to understand what do they mean. So for example, if I have a 5-minute RR interval or heart rate data and I plot heart rate as a function of time, so I will get a tachogram or a record something like this. On the y-axis we have the heart rate, and on the x-axis we have the time or the interval number. Now once this heart rate is converted into RR intervals, so we can see in both the records a lot of fluctuations are present. Now heart rate variability parameters, they try to classify or quantify the fluctuation or the scatter in this data. So we have parameters such as SGRR, that is the standard deviation of the RR intervals, which represent the overall influence of the autonomic nervous system on the heart rate. Then we have NN50 and PNN50. NN50 is the number of intervals varying by more than 50 milliseconds with respect to the previous beat, and PNN50 is the percentage of such intervals in the total recording. So these three parameters quantify the variability based on the RR intervals. Then the next step is what I do is I calculate the difference between the RR intervals. So instead of the RR intervals, I subtract every subsequent RR interval from the previous RR interval and plot them as a matter of time. So again, I will see that some of the values will be higher than 0 and some of the values will be lower than 0, because heart rate will go up and down with time. So the difference in RR intervals, the magnitude of scatter here or variability here can be used to compute the root mean square of the standard deviation and the standard deviation of the RR intervals. So these parameters are there in the time domain, which can be computed and they can be compared with normative age-matched data. Then for the purpose of frequency domain analysis, this RR interval tachogram undergoes a mathematical technique that is known as fast Fourier transform. Fast Fourier transform is one of the methods of spectral analysis, wherein this RR interval time series undergoes a mathematical calculation by FFT, and now we plot a power spectral density plot. So as the name suggests, it is a plot of the spectrum, that is the frequencies, and the y-axis represents the power or the amplitude of the frequency. So this power is proportional to the total energy that is there in particular frequency band, and based on the experiments shown by Axelrod and other studies, these frequency bands are classified into 0 to 0.04 Hertz, 0.04 to 0.15 Hertz, and 0.15 to 0.4 Hertz. And these are classified as very low frequency, and high frequency. Based on the experiments conducted in animal studies, we know that the VLF frequency is mediated by respiration. Low frequency power, the height of the peak in the low frequency band is primarily because of the sympathetic nervous system with some contribution from the parasympathetic nervous system. And the HF band, the power in the high frequency band, is because of the parasympathetic nervous system. The ratio of LF-HF serves as the LF-HF ratio is an indicator of sympathovagal balance and tells about the balance between the sympathetic and parasympathetic nervous system. So again, for purpose of comparison, the total power and other parameters can be derived in an age-matched population and they can be compared with normal data. The second part of this assessment is the autonomic reactivity. Autonomic reactivity, reaction talks about a response. So these autonomic reactivity parameters tell us about the response of heart rate and or blood pressure in response to physiological stimuli. These physiological stimuli include the change in posture as demonstrated in the morning. Lying to standing or head up tilt test can be used for this. Then slow breathing, deep breathing test can be used. Valsalva maneuver can be done by forced expiration into a pressure measuring device to maintain an effort of 40 millimeters mercury for 15 seconds. Then we have hand grip exercise, doing isometric exercise at 1/3 of the maximum capability for a period of 4 minutes. And we have cold stimulation test, which is immersing hand in 10 degrees water for a period of 1 minute and then seeing the response. The heart rate responses are primarily driven by the parasympathetic nervous system. Therefore, heart rate differences and ratios represent parasympathetic measures. And the changes in blood pressure, systolic BP or diastolic BP, are mediated by the sympathetic nervous system, and they represent sympathetic indices. Now, we can use a scoring system to classify the criteria as normal, borderline, or impaired based upon the standard cutoff proposed by Ewing et al. So this is one of the publications by AIIMS New Delhi, wherein the criteria have been referred to, and then they can be used to grade or classify CAN into normal, early, moderate, or severe. So I'll show you some of the representative record. This is a record of lying to standing test. This black bar represents immediately when the patient has stood. So you can see that there is a rise in heart rate, which reaches a maximum at around 15th beat, followed by bradycardia, the nadir, at around 30th beat. This can be used to calculate 30-15 ratio, and BP changes can be documented concurrently. This is a record of deep breathing test, wherein we can see inspiration and expiration. So we can see tachycardia during the inspiration part and bradycardia during the expiration part. So 6 cycles are recommended for the purpose of deep breathing test. Then Valsalva maneuver, forced expiration and in an open glottis into a pressure measurement system. So we can see this period, the period between the dotted lines represents the Valsalva maneuver. We can see that the patient is actively exhaling. There is tachycardia during phase 2 or during the Valsalva maneuver part, followed by bradycardia after the maneuver. So their ratio, RR interval, can help us attain the Valsalva ratio. All these parameters again can be tabulated, compared with normal, borderline, or impaired, and based on all these we can use grading for cardiac autonomic neuropathy. 2 systems of gradings are commonly used. One is the Ewing's system, again that was mentioned in the handout given to you in the morning. Ewing system classifies the cardiac autonomic neuropathy as normal, early, definite, or severe. So based upon the number of heart rate and blood pressure tests, normal or abnormal, we can classify using Ewing's criteria. We can also use AIIMS New Delhi criteria, wherein separate grading has to be done for the sympathetic and the parasympathetic component, and this can be classified as normal, early involvement, or definite involvement of the limb of the autonomic nervous system. Based on any of these 2 criteria that you may follow in your lab, you can quantify cardiac autonomic neuropathy in one date, and you can maybe pursue a follow-up study to see whether the grading has come down with time on the institution of therapy, it is staying as same or worsening with time, and a comparison can be done. Then I'll quickly discuss some of the papers that we have published in this area. One of the papers, or one of the common questions that was put to us by our clinician colleagues, was that are these tests repeatable and reliable when done by a single observer? So we designed a simple cross observational study wherein a single observer took 31 healthy subjects. She performed autonomic function testing in HRV and Ewing's battery on the morning and afternoon of the first day, next day, 1 week later, and 1 month later. And we found out in our study that time domain parameters have a good to excellent repeatability. So if for the same subject repeated assessment is done by the same observer in the same conditions using the same equipment, time domain indices are highly reliable. For frequency domain, it is almost moderately to poorly reliable, probably because the rate of respiration was different for the different visits, and VLF power differed between the visits. Then for the reactivity measures that proposed in the Ewing's battery, we found them to be very robust with the exception of lying to standing test. All the other measures repeated good to excellent reproducibility. So if in the same subject the parameters are done in the standardized condition repeatedly, even for a period of 1 month, the tests are highly reproducible and highly repeatable. Another work we took on, we had data of healthy subjects, and we had repeatedly come across the notion that obesity causes sympathetic overdrive and causes the parasympathetic decrement. So we took 105 apparently healthy adults performed HRV and Ewing's battery of tests and classified the subjects according to Southeast Asian criteria of obesity and WHO classification of obesity using BMI as a corrector. So we found out that WHO criteria actually it underestimated obesity in our population. By using Southeast Asian criteria, more people were flagged as obese because the BMI cutoff for them is lower. Then interestingly, we did not find any difference between normal weight, overweight and obese subjects based upon the Southeast Asian criteria. So if we classify subjects according to the criteria and look at how obesity has an effect, in the small sample that we have, we could not find any effect of the classification of obesity having a bearing on that. And larger samples are probably needed to understand this relationship in a better way. Then one again a question that was coming to our mind, that what is the effect of the software tools that are used for the purpose of analysis. All the software, they have inherent inbuilt algorithms and different processing criteria and capabilities. So what was the effect of using different softwares for the purpose of HRV? So again we took healthy subjects, 53 apparently healthy subjects. We took 5 minutes of ECG epoch, and that was again analyzed by a single observer using popular HRV analytical software such as LabChart, Neurocard and Kubios, and we found out that there is some difference between the time domain and frequency domain parameters, and they are affected by the software that is being used to analyze. If you carefully go through the documentation, you will find that softwares have different pre-processing criteria, different methodologies for performing fast Fourier transform. Some use a Welch periodogram, some use a Lom periodogram, and therefore the inherent differences are there. So this effect was seen more on frequency domain parameters. Time domain parameters were almost consistent across all software. We were getting the same values, but because of inherent differences in the fast Fourier transform, the frequency domain processing, there was difference in the frequency domain parameters, and bias was observed between the softwares. Then we took some studies in diabetes mellitus, wherein VGF, we explored VGF, whether it could serve as a marker of CAN. We took newly diagnosed patients with of diabetes mellitus, subjected them to HRV and Ewing, and we found out that none of the patients had abnormal cardiac autonomic reflex test. All of them had impaired HRV. HRV was on the lower side as compared to healthy age matched control group, but the reactivity tests were within normal level. And in the same subgroup, we found that VGF levels were elevated. When we reviewed the literature, we found out one proposal, one theory, that VGF is actually protective against cardiac autonomic neuropathy, and probably this was serving as a marker of protecting the patients who were newly diagnosed with diabetes mellitus, and elevated VGF was probably a protective factor against cardiac autonomic neuropathy, and we propose that this can be used as a marker, as a biochemical marker. Then one interesting study we undertook in the ultra short HRV. Now everybody, with the rise of wearable technology, smart watches are available, heart rate is being measured from the wrist using photoplethysmography. So we wanted to look whether short epochs of HRV, whether they can be used as a reliable surrogate of 5-minute HRV data. So we took the HRV epochs of 1 minute, 2 minutes and 5 minutes, and we used retrospective data of patients with diabetes mellitus who had reported to our lab. We used data of 137 subjects, and we found out that there was the moderate to good reliability or intra-class correlation coefficient between the parameters reported on HRV. The only caveat of the study being that once we use shorter HRV epochs of say 1 minute or maybe of shorter than 1 minute, then frequency domain parameters cannot be reliably commented upon, because the number of cycles that are captured in that short window are too few to give us an overview of the frequency spectral components. So to summarize, cardiac autonomic neuropathy can be diagnosed easily in the physiology lab, in the clinical lab, and it should be instituted right at the time of diagnosis for patients with diabetes mellitus. Annual screening should be done as recommended by the Toronto panel and as per the latest ADA guidelines. And this is important because the progression from subclinical to clinical to the severe symptoms can be documented right at this chart. Some corrective measures can be instituted, and serious complications such as orthostatic hypotension, risk of injury because of fall, silent MI can be prevented and some change in the clinical outcome of the patient can be done. So with this I wind up. I would like to thank again all the giants whose shoulder I have stood upon to have be able to do some work in the area of autonomic neuropathy. Professor K.K. Deepak sir, Professor Jaryal sir is sitting here. Then I am also thankful to the senior residents who were there when I joined the department. They served as role models for me and I learnt a lot from them. Dr. Dinu sir, Dr. Kiran Prakash madam, Professor Manpreet Kaur madam and Dr. Kumar sir, they have been the guiding light, if I may say, in my academic journey. Also, I'd like to take a moment to express my gratitude towards late Professor Rajesh Kumar Sharma sir. Sir was a professor at AIIMS Jodhpur who established the autonomic function testing lab there. Unfortunately, sir is no more, but we are trying to follow in his footsteps and trying to do more tests and serve as many patients as possible. And also, I'd like to take time to thank all the faculty members of my department at AIIMS Jodhpur. And last but not least, I'm very thankful to all the residents who are working in the lab, helping in the patient testing and generating timely reports and helping the clinician in diagnosis of autonomic neuropathy. Thank you so much.
Any questions? No? This itself shows you have made it so simple and how informative it was, Dr. Srivastava.
Thank you so much.
Thank you so much. Your CV is so very impressive. I was just listening to the whole list. So many awards, so many publications, and you have delivered the message about the importance of the battery of Ewing's tests so that you can stop the progression right from the early phase to further leading to the mortality, LV dysfunction and all those things. Thank you so much for your talk.
Thank you all of you. Thank you ma'am for inviting me here.
You want to say something?
More for the
Thank you,
youngsters,
sir.
because what he mentioned about the wearable technology, most watches now can give a parameter, and your stress levels. Don't rely too much upon them. Don't do that. I'll tell you. First primary reason is the technology which is used. See, they do by measuring the pulse photoplethysmography. There's a difference in ECG and timing of contraction. There's a delay. Okay, so and it's not constant. So you may have the ECG coming at some time and there's a gap of pulse travel time, which is not constant. It changes with breath, even respiration it changes. So it's not a very good marker as a technique per se, number one. The amount of data that it takes is also not good. So it may be, it's like in the hospital, when you do a photoplethysmography, the equipment costs around ₹1 lakh. The very expensive equipment. And when you buy a photoplethysmography from the market, it may give about ₹500. You would say, जब 500 का चीज़ है तो hospital में महंगा क्यों खरीदते हैं? Is the reliability. And therefore, therefore it's very so fancy. अच्छा है for maybe looking at each other. How long can you hold your breath? That kind of nice passing time, but don't use it to guide yourself or get stressed by what you see. You see, it's a self-fulfilling prophecy. You tell somebody you look stressful, the person will become stressed. If you tell somebody, oh, you're looking happy today, the person starts feeling happy. There's a very strong power of mind in sort of, we can convince somebody to be happy or sad. The moment you see a watch and watch saying you look stressed, you are stressed now. So I think that's a caution you may take from that, because like that didn't mention. Thank you, ma'am.
Thank you so much, Dr. Srivastava.
Thank you, ma'am. Thank you, sir. We shall now, I kindly request Dr. Gauri, Professor and Head of the Department of Physiology of MGM College, Jamshedpur, to give away a token of appreciation to Dr. Shival Srivastava, sir. So that was a wonderful talk. So please, sir. Please, please, sir. Give a round of applause, please. Thank you, ma'am. Thank you, sir. Ma'am, yeah. We would now like to proceed to felicitate our moderator, Dr. Gauri, and I request Dr. Raghvendra Rao, Associate Dean, Preclinical and Professor of Department of Physiology, MTMC, Jamshedpur. Round of applause, please. May I now request Dr. Hiruk Chakravarti, Associate Professor, Department of Physiology, MTMC, to kindly introduce the upcoming speaker. Over to you, sir.
Thank you, Dr. Shilpa. It gives me immense pleasure to introduce a highly respected and accomplished physician, Dr. Rajesh Kumar Thakur, who hails from Jamshedpur. Dr. Thakur has completed his MBBS from A.N. Magad Medical College, Gaya, Bihar, and went to pursue his MD in general medicine from VSS Medical College, Bola, Sambalpur, Odisha, where he also served diligently in cyclone-affected areas during the devastating super cyclone of 1999. In 2001, Dr. Rajesh Kumar joined Tata Motors Hospital, Jamshedpur, and since then he has steadily risen through the ranks from senior medical officer to now head of the Department of Medicine since 2018. His dedication and clinical acumen have earned him multiple accolades from Tata Motors over the years. He has received specialized training in upper and lower GI endoscopy under the renowned Padma Shri Dr. Nageshwar Reddy at AIG Hyderabad, and has been performing both diagnostic and therapeutic endoscopic procedures, including EVL, since 2005. In addition to his clinical practice, Dr. Thakur has attended a workshop on disaster management in Kolkata and has presented numerous papers and talks on topics like hepatobiliary diseases, MASLD, endoscopy, heart sounds, and COVID-19 management. During the peak of the COVID-19 pandemic, his exemplary contribution to managing ICU and ward service patients received recognition in the print media and appreciation from the CM of Jharkhand. He also plays a pivotal academic role as a regular teacher and examiner, both internal and external, for DNB students. So please join me in welcoming Dr. Rajesh Kumar Thakur to the session. Sir, please.
And the session on recent advances in diagnosis and management of diabetic neuropathy will be moderated by Dr. Sunita Hutta ma'am, former ex-in-charge dean and professor of MTMC and professor of biochemistry, MTMC. Ma'am, we request you to take the seat to moderate the session. Over to you, sir.
Good afternoon to all of you. Respected senior colleagues and dear students, good afternoon. Feeling sleepy or not? Okay. So now we are shifting the paradigm from basics to the patients, okay, in clinical practice. So we are going to talk about recent advances. Can you tell me, students, what was the oldest treatment of diabetes? What was the oldest treatment before insulin, in pre-insulin era? Riding over horse. Why? Why we were riding over the horse? Because in pre-insulin era, it was defined that flesh and bone is melting into the urine, defining diabetes as saffron. Okay? And mellitus means honey. So a saffron with honey. Okay? So at that time, we used to ride the horse to avoid the polyuria. As our thought was there, everything is melting through the urine. Okay? So, but from that time, flesh is melting into the urine to now the stem cells and genes. So, can we revert the diabetes? Is it possible? Let's see. As we know, the diabetic neuropathy almost affect 50% of the diabetic individual. And once it has occurred, it cannot be reverted back. So what we can do? We can do only, we can delay the progression of disorder. Okay? So that's why all the diabetic patients should be screened at the time of diagnosis, and in a case of type 1 DM, at 5 years after the diagnosis, and then annually. So all people should be screened at the time of diagnosis. And remember, out of the 3 microvascular complications, this one is most ignored part of the clinic. Okay? As we know, it is a very serious complication. I will show you the consequences of diabetic neuropathy. And it is mostly related to chronic hyperglycemia induced nerve damage. Okay? What are the risk factors? You can see there are 2 halves. One is showing painful, another is showing plain diabetic neuropathy. That painful is only a co-founding factor, just a co-factor. Most important thing is glycemic control. Glycemic control is very important in diabetes. Okay? Glycemic control. They should control the sugar first by lifestyle modification, by diet as well as physical exercise. When, whatever the comorbidity they are having, accordingly them. Okay? And second one is metabolic syndrome, like dyslipidemia, other obesity. Obesity is very important in India. Nowadays we are going to mirror the global image, and in India the obesity definition has been changed. Now in India BMI of more than 25 is obese, but concern start from the 23. So be careful. In India it is different. Okay? Lifestyle, especially cigarette is very bad. So whoever the smoker, they should stop smoking. Okay? Inflammation, both local and systemic inflammation play a very important role. This inflammation used to produce pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin 1, 6. They all causes damage to the cells. Okay? So this inflammation is very important. Genetics play a role. Genetics definitely play a role. BMI, as we have discussed, BMI is very important. And another, this female sex, they are associated with the just as a co-factor for the painful neuropathy. We'll brief we'll brief the pathogenesis. There are 3 factors: insulin, either deficiency or resistance. Because pathophysiology differ in type 1 than type 2. In type 1 there will be absolute deficiency of insulin. Okay? And there will be relative deficiency as well as resistance in a case of type 2 DM. if you will come to hyperglycemia part, see, in hyperglycemia, what will happen? Excess of glucose will enters the polyol pathway, okay? And that polyol pathway as well as the hexokinase pathway and protein C kinase pathway, that will lead to more formation of oxidative stress as well as they are the precursor of neuronal apoptosis, okay? And this hyperglycemia, again, what will happen? Chronic hyperglycemia will cause the non-enzymatic glycation of the protein, lipids and nucleic acid, leads to the formation of AGE, that is advanced glycation end product, that is carboxymethyl lysine or carboxyethyl lysine, okay? And ultimately they bind the receptors, and these are the things happening, and dyslipidemia, it is producing excess amount of free fatty acid, and ultimately these are causing to DNA degradation, hypoxia and macrovascular damage. And there, from this excessive polyol pathway oxidative stress is causes the mitochondrial dysfunction, and ultimately leading to this neuronal cell death, monocyte requirement, macrovascular damage and myelin depletion. So this is just in brief a pathogenesis. Here we will see where the medicine will work. Just in a brief classification. Distal symmetric, it is around 50%. It is very common. Usually patient present with the globe and stoking like sensory loss. These are the most common type of presentation in the either OPD or ward. Another is autonomic, already discussed very nicely, CAN, GAN, everything, okay? And mononeuropathy used to involve cranial nerve, 7th, 6th, 4th or peripheral nerve like median. And radiculopathy, that is amyotrophy, it used to involve less than 1% of patients, usually involve the sacral plexus and cervical. Coming next, see, this is the consequence. This patient was admitted with the HbA1c for 12.5. See the condition. See the condition of this patient. Same patient had this gastroparesis. Okay? He was, ultimately we have evacuated the stool from the rectum. Now the recent advances, I think Dr. Srivastava has already explained all these things. Fews are there like skin biopsy for the intradermal nerve fiber density and CCM, corneal conofocal microscopy. It is very important in an early marker. It can detect the neuropathy in a very early stage. It was observed in type 1 diabetes that it can detect up to the 29% of the patient. CCM. Another is pseudoscan, another is high resolution, either CT or MRI or PET. They can detect the even fibrosis of the nerve, edema, thickening, they can detect with high resolution. These are the newer techniques coming and just on the pipeline. This is the images of this IFND, where it used to do at 10 centimeter above the lateral malleolus. It is an invasive process. It used to take 3 mm punch biopsy. And you can see that side is a normal corneal fiber. This side is reduced in density and reduced in length. This CCM. I don't know, it must be available in AIMS, I think so. Pseudoscan, it tests the sweat glands. These are the biomarker which are under investigation. Nerve growth factor. It is classically reduced in diabetic neuropathy. And another inflammatory marker, as we have discussed, interleukin 1, 6, TNF alpha, kits are available. Kits are available in the market, you can detect. And AGE, like this carboxymethyl or carboxyethyl, you can measure AGE. MicroRNA signature from the excretion, you can take it. Goal of therapy. What is the goal of therapy? Goal of therapy is not only nowadays glycemic control. Nowadays we are thinking in line of prevention or reverting it back. So we are trying, trials are going on to revert back the disease. Okay? So, disease modification as well as prevention. At least today, till date, at least we can slow the progression of disease by diet control, by lifestyle modification, and by pharmacotherapy. These two medicines are approved for the analgesic pregabalin as well as duloxetine. Pregabalin start with the 75 milligram. You can go up to 600, but 300 is sufficient enough because patient will have lots of side effects, sedation, etc. And duloxetine you can start with the 20 milligram and you can go up to 60. Titrate the patient, see the effect. Okay, so that is important. These two are approved. By the way, we used to give amitriptyline too. We also used to have amitriptyline. Gabapentin we have also given, but it has got very much sedation. Gabapentin got very high sedation, even in the dose of 100 milligram. This is a alternative, is used in a case of refractory case, tapentadol. But here the risk of dependence is there, as it is a opioid. So risk of dependence is there. So be careful in this. This is the graph, this is the table showing the conventional treatment. On the left side you see lifestyle modification. That means glycemic control, both in type 1 diabetes work very nicely and type 2 DM as well. Lifestyle modification, I am telling you, exercise, physical exercise is very important. Now the recommendation from for India is around 150 to 300 minutes per week for healthy individual, not with the cardiovascular disease or not with the osteoarthritis. Okay, minimal intensity exercise like brisk walking. But for high intensity exercise, it is recommended 75 to 150 minutes per week. Okay, like intense exercise, you are doing push-up, you are doing other gym like that. Okay, so for that 150 minutes, otherwise 300 minutes per week. Okay, and now coming, this is a mechanical based treatment. See here, methylcobalamin. It is a neuroprotective vitamin. It is a form of vitamin B12, methylcobalamin. So you can easily give this. It will definitely help. These are the neuro-regenerative things coming in new literatures. Okay, methylcobalamin, alpha lipoic acid act as an antioxidant, act on the reactive oxygen species. Okay, in the dose of 300 up to 300 milligram. Apleristate, here apleristate, polyol pathway where aldose reductase is the rate limiting enzyme to converting from the glucose to fructose. There it works, apleristate and ranitidine, that is aldose reductase inhibitor. It is also coming. And this prostaglandin is naturally occurring. It is a just enhancer. And another is acetyl L-carnitine, there is a metabolic enhancer. Now coming to the painful diabetic peripheral neuropathy, as we have discussed, anticonvulsant, these are effective here. These are effective here in the correct doses. SNRI, like duloxetine, here we can give from the 20 milligram. And sodium channel blocker, oxcarbazepine, carbamazepine, new sodium channel blocker is also coming, locosamide. It is available in India in 50 milligram dose. That I will come. And second, if it fails, you can combine the two medicines. If it fails, second lines again comes the opioids and topical agent. Topical agent most commonly used capsaicin. You can apply capsaicin at the 4 places for 30 minutes and on the leg, and you can repeat it after 3 months. It is available in market. Or you can give lidocaine. And these are the neuromodulation. Neuromodulation, that means spinal cord stimulation, TENS, every physiotherapy unit has got this thing. So you can use this neuromodulation. This is the just overview we all have already discussed of ANS, cardio, gastro, pseudomotor, genitourinary. Here no single drug is available. treatment is symptomatic. All treatment is symptomatic. We are coming. Goal is symptom relief and functional improvement. Like orthostatic hypotension, if it has been proved, if you have examined the patient carefully, here you can use the midodran, that is alpha 2 agonist, in the dose of 2.5 to 10 milligram up to 3 times daily. It depends upon the, but supine hypotension is the side effect. So be careful. And you can combine the midodran with fludrocortisone. That is a salt and will cause the retention. That is the volume expander. Droxidopa, new medicine is coming in the dose of 100 milligram. It is a norepinephrine precursor. It is now coming. Another pyrodoxine already there. We can use from the dose of 30 to 60 milligram. It is a cholinesterase inhibitor. It allows acetylcholine to accumulate the ganglia and enhances the nerve functions. Supportive is compressive stoking. This is very important. We are using it. We are using it in the regularly in the ward. So this used to help in a very good manner. Gastroparesis already discussed. You can give metoclopramide, domperidone, erythromycin. It depends upon the patient's response, how the patient is responding, what the side effect is coming. You monitor and titrate the patient accordingly. And diarrhea, newer you can use rifaximin. Rifaximin is a very good medicine. It works in even hepatic encephalopathy by reducing the production of ammonia. Here it stabilizes the gut microbiomes. New therapy is coming, FMT, fecal microbiota transplantation. Okay, so this is a new therapy is coming. This is a very good therapy to enhance the production of short chain fatty acid that work as a anti-inflammatory. Okay, that is a very good thing that is coming. Neurogenic bladder. I think most of the diabetic patients, type 2 diabetes especially, I am telling you, we are dealing with the type 2 diabetes mostly. Most of the peoples are having this bladder dysfunction. They are either PBRU is very high or incontinence is there. There are lots of medicine is there. Tolteramide is there, oxybutanin is there, that is M3 receptor. New one, mirabegron is there. That is beta M3, that has also got very good result in this condition. Overactive bladder, that has got a very good result. That 3 drugs, tolteramide, oxybutanin and mirabegron. And here you can use bethanacol or intermittent catheterization as already discussed. And phosphodiesterase inhibitors, in a case of this ED, you can use either sildenafil or tadalafil in the dose of 25 to up to 100. You can go titrate accordingly, but it requires the behavioral therapy, positive cognition therapy, patient education, self-care, awareness, contraindication. You must consider patient is not having coronary artery disease, okay? Otherwise there will be coronary vasospasm. Lena ka dena pad jayega. And this is newer addition, alprostadil, that is PG analog. It is just coming now. It is either injectable or intraurethral tablet is available. Okay? It should be used in the interval of 3 weeks. Okay, but be very cautious. This is a newer addition. Hyperhidrosis, you can use this gel. This gel on face, axilla, where the hyperhidrosis is occurring. It is available in the market. You can use this gel. Okay, anhydrosis, you can use emollient. And I'm telling you, if this ammonium chloride and glycopyrrole doesn't work, you can use this botulinum that used to work for 3 months, one sort of injection. But very careful, be very careful. Pupillary dysfunction, you can use pilocarpine or tinted glass. That is just for the symptom relief. Now coming to the recent treatment, it was up to the conventional treatment. Recent treatment, what the recommendation is coming according to the ADA. Diabetic control and complication trial and UKPDA studies showed reduce risk with tight glucose control. Please remember, please remember, please remember. Glycemic control is very important, as well as the duration of illness is also very important. So by glycemic control, you can achieve so many things. Even you can prevent the neurodegenerative changes. So it is very important. And newer thing, SGLT2 as well as GLP-1. How SGLT2 helps? SGLT2, first it controls the hyperglycemia. Then it prevents the endothelial dysfunction. It also prevents the oxidative stress. And it also works as an anti-inflammatory. And what is the role of GLP-1? GLP-1 is secreted by the L cell of intestine, L enteroendocrine cell of the intestine. In a glucose-dependent manner, it causes the release of insulin from the pancreas. And it inhibits the secretions of glucagon. And it used to delay the gastric emptying. And it used to enhance the satiety. So, and it is also a neuroprotective. So, it is just coming in the recent literature. So, these both help together or alone. These are the few combinations which is recommended by the ADA. Duloxetine and pregabalin, newer regime and combination is recommended. As we have discussed, new sodium channel blocker, that is locosamide in 50 milligram is under evaluation. It is not approved till now. Alpha lipoic acid antioxidant, capsaicin already we have discussed 8%. Non-pharmacological like a TENS or neuromodulation, that also used to help the patients. Benfotiamine is a B1 thiamine agonist that reduces the formation of AGE. So it is also coming. Omega-3 fatty acid, it is considered that the eicosapentonic or dexahexoic, they are a cardio-neuroprotective as well as anti-inflammatory. So these are available in the market. Newer gastroparesis agent is relomorelin. Relomorelin, it is a ghrelin analog. What is ghrelin? Ghrelin is a hormone secreted by the duodenum on the entry of nutrients. It acts as a appetizer. That it used to enhances the gastric emptying. So it is now coming. Neurogenic bladder botulinum toxin can be used. Cardiac autonomic neuropathy is very nicely discussed. Here we can use ivabradine. What is ivabradine? Ivabradine is if or funny channel inhibitor in SA node. Okay, we can use ivabradine in a heart failure with reduced ejection fraction, and it is very much indicated even in a case of hypotension, and it does not affect the contractility of the heart in the dose of 2.5 to 5 milligram. So it is a very good medicine for control of heart rate. We are using it. So many patients, they are taking ivabradine. Or neuromodulation like transcutaneous stimulation of the vagus, like that. Pseudomotors, that is symptomatic only. Now these therapy are coming. Regenerative therapy. What is this? Stem cell, gene, and the neurotropic factor delivery by a nanoparticle. How we used to deliver this neurotropic factor? It increases the efficacy as well as specificity of the therapeutic agent, increases the bioavailability, minimizes the side effect, and optimizes the treatment. This nanoparticles. Monoclonal antibody. This tenazumab binds and neutralizes the NGF, that is nerve growth factor, and reduces the sensitivity of the pain. Now coming to the another table. This is the emerging therapy. You can see I have divided into 1, 2, 3, 4, 5, 6 part. Start from the stem cell therapy, that is either mesenchymal or induced pluripotent stem cells. It works on the neuron. It increases the BDGNF. Gene therapy, it increases the VEGF as well as hepatic growth factor. As we have discussed, microbiota therapy increases the short chain fatty acid. that acetate, propionate and probiotinate, that take care of the inflammation. That is a very new thing that is coming as a brain gut axis, okay, or brain gut syndrome. It is coming nowadays. These are the few new biomarkers like methylcobalamin, sodium oxide dismutase, neutrophil to lymphocyte ratio, HI1 receptor blocker, and NSE, then had a heavy chain. These are the newer biomarker. And again we will go to hyperglycemia. Sorry. Here you can see this AG is prevented by the benfotiamine, and here again SGLT2 and GLP-1 agonist, they used to control hyperglycemia, and they also work as a to enhance the endothelial reduce the endothelial dysfunction, reduce oxidative stress as well as anti-inflammatory. Canagliflozin we can use, and SGLT2 any of GLP-1. Just recently in the last week it is launched in India, semaglutide in the dose of 2.4 milligram once weekly. Cost is 27,000 for 1 month, okay, but start the dose with 0.25 milligram per week, gradually go to the 0.5, 1, then 1.7, then see the side effect, titrate the patient, but ultimately you have to reach the 2.4. I think it will take around 17 weeks to reach there. So these are the very good medicines. And here are miragabalin, which is a congener of pregabalin, and another is sodium channel blocker, dextromethorphan NMDA agonist, clonidine gel also we can apply. So these are the, and tanazumab again that binds the NGF. That all summarizes the emerging therapy. Future direction. Now the AI is coming. AI is increasingly being used in the healthcare. It can create large data sets by processing genetic information, clinical variants as well as imaging. But drawback is privacy and ethical consideration. So this is important. Lots of, as Dr. Jarial was speaking, lots of sensors are coming nowadays, wearable sensor. Even the smart sole and smart socks are coming with the sensation of temperature and pressure. You wear it, they will tell you whether you are going to develop this thing or not. So lots of sensors are coming. Personalized medicine. Personalized medicine, what is it? Personalized medicine, it helps. It helps for the early diagnosis and treatment and categorize it properly, categorize the patient properly. It based on the genetic and molecular thing. Nowadays, personalized medicine is very hard topic. It is coming very nicely nowadays. Concluding all, recent advances offer hope for early detection and effective management. Multimodal and patient-centric means, as we know, these are a multifactorial disease. So it requires a pharmacological as well as non-pharmacological way of treatment, like lifestyle modification, behavioral therapy, self-care, physical exercise, dietary advice, or involvement of endocrinologist, neurologist, all the super specialties you can involve, and it should be patient-centric. You look for the patient's comorbidity. Patient is having either any cardiovascular comorbidity or any other comorbidity like malignancy. So you have to think about other comorbidity. And now this ongoing research, as we have discussed, the paradigm of diabetes is shifting from the old conventional method to method focusing more on the nerve metabolism. Basically, there is interaction of the lipid, glucose and bioenergetics in the peripheral nerves. Thank you.
Thank you, Dr. Thakur, for such an, I should say, it was such an amazing presentation. You have explained everything so in detail about the recent advances for the management of the patient as well as in the diagnosis and pathophysiology and everything. We are really thankful, and I hope all the participants must have learned how to detect. By this time so many methods has been told to you people. So you must have known by this time how to detect early all these autonomic changes in case of diabetes mellitus. So diabetic neuropathy can be detected early and all the complication can be treated nicely. Thank you, sir.
Thank you, ma'am. Any questions?
Sure. Ivabradine is a very safe medicine. You will have to continuously monitor the heart rate. It is indicated in a heart failure with reduced ejection fraction. Okay, but if tachycardia is there, only you can, in that condition you can give ivabradine. Okay. 100, you start it. You start it. It is a very good drug. It is not. It has nothing to do with the contractility of the heart. It is a very good medicine. My so many patients are on ivabradine. Thank you.
Any other questions?
The discussion came on ivabradine. So ivabradine came into market around, I think, 2008 or around that, sir?
Yeah.
Yep. So I was taking lectures for first year students. So I was preparing for these lectures. So we checked PubMed, everything. So I came across this drug that is being launched in India. And the drug was, as he mentioned, was very beautiful in the idea that it only affects the SA nodal pathway.
If channel or funny channel.
HSA is what we call it. That means the drug will prevent the heart rate changes. The problem with the beta blockers was it affects everything else. So very selective. So as we were in Autonomic Function Test laboratory, ये तो हमारे लिए भी अच्छा है, because we are looking at the heart rate only. So like, can we try? So I found out the initial samples. Took safe ही होगा humans के लिए. So I took those samples to see, and it actually affected. But then it had some issue in the sense that because heart rate now doesn't increase. So if you start doing some activity, now you don't get a
TMT को उसके बाद मत करने लगो.
Because it will be falsely made. So that I got reminded of that. Thank you for bringing that idea.
Thank you, sir. Any other questions?
Does it only act on the Usher node or AV node and Purkinje fibers and everything?
It works on the APE channel of the SA node.
Okay, only for Usher node. So it cannot be used in WBW.
No. For WBW you require different thing, totally different. WBW is present with the AF, then you will be in trouble.
Any more questions? Okay. Thank you, sir. I kindly request Dr. Sunita Hota, ma'am, ex-dean of MTMC and presently a professor of biochemistry, to kindly give a token of appreciation to Dr. Rajesh Thakur, sir. A big round of applause, please. Thank you, sir. Thank you, ma'am. Ma'am, we would like you to stay back. Ma'am, we would like to give our appreciation for moderating the session, and you were kind enough to take, take the job of a moderator without any hesitation. Thank you once again, ma'am. Okay. Thank you, sir. Thank you, ma'am. We have now arrived to the final segment of today's CME, the Neuroquest. I invite Dr. Raghvendra Rao, the driving force behind this initiative, to take forward the Neuroquest on diabetic neuropathy. So, over to you.
Good evening. Hope you had a nice academic sessions. MTMC endeavors to engage students for all such co-curricular activities. And they have done wonderful, they have fared very, very well. We had anatomy Rangoli, Biofest quiz, Physiocraft, and also we have started a competition called Crossword in Physiology, Crossword quiz. And we have organized a preliminary round for all the classes, all the students of the class on different topic. Today's topic will be this, diabetic neuropathy. The finalists are 5 groups. We have identified 5 groups. I will call the names. They will now undergo this competition. The competition is little tough. Those who are familiar with, or all of us are familiar with crosswords. There's not much attempted in medical science. I have selected about 27 words, which are all about autonomic neuropathy or diabetic neuropathy. I'll be giving some sheets. One is the grid, crossword grid, and the other one is the question. I'll call out the names of the students. Aditya Pandey, please come to the front. These are the finalists. Vaibhav, Shrestha Prasad, Mantasha Malik, Rajiv Kumar Ranjan. This is the first group. Please come forward. Come forward. Please come to the front. Please come fast. Please come. Come here. You will be the yellow team, okay? You will be the yellow team. Please occupy one. Yeah, please go. Next is the green team. Swati Snehal, Divyanshi Singh, Tanu Kumari, Sneha Singh, Achal. Please come front. They are the green teams. Orange, Sakshi Shri, Aditi Srivastava, Manav Mishra, Ikanksha Rai. Next is the blue team. Okay, tell. Oh, Nikita Nayan. Sorry, orange, Nikita Nayan is also included. Blue team, Utkarsha Chaudhary, Riddhiman De, Anjali Chanchal, Shashank, Ankur Gangwar. Your blue team. Next is the last is the pink team. Shashwat Rana, Ankit Kumar, Karan Bharadwaj, Arya Mishra, Anushka Malik. Please push them separately. Those who are here also can participate. We have some sheets we can give you if you want. You can enjoy doing. This will be for 45 minutes. Can relax, come back. Yeah. Put them separately. To the students, are you ready? Are you ready? There are 2 sheets which will be given to you. One is the grid table crossword grid. Other is a question. You will be given. What about the? Yeah, start. We will start the quiz. No cell phones, no support from anybody from your. Please don't tell anything. If you get the paper, anyway, you can also participate. Audience can participate, but no competition. You can enjoy doing it. 4:30. Yeah. Just a clue or key for you. Do the down first. Down one first. It will be easy. Across later. पहला down करो. Down वाला. There are some cryptic clues. So be careful. Cryptic clues are there. Hidden. Yeah. तीन हैं अभी तक।
And those who want to have the tea served outside the auditorium, I request all the delegates to go and have the refreshments. coffee.
With
Two
biscuit.
coffee there. We will only take two coffee. So ये ट्रे में ले जाएंगे. वो खुला है.
मैडम बिस्किट चाहिए. आ रहा है वो प्लेट, बिना प्लेट के देगा नहीं.
तो मैं जोर से पूछता हूँ. हाँ मैंने
घर में सब कुछ.
ಎಲ್ಲ ಚಹಾ ಕುಡಿದೆ ಆಯ್ತು, ನಾನು ಒಂದು ತಂದು ಕೊಡಲಿಲ್ಲ. ಬ್ಲ್ಯಾಕ್ ಕಾಫಿ, ಬ್ಲ್ಯಾಕ್ ಕಾಫಿ ನಾನು ಸತ್ತು ಹೋಗ್ತಾರೆ. चिकन अच्छा था, एवरीबडी से चिकन वाज गुड. ಮಾಡ್ತೀರಾ ಅನೌನ್ಸು? I don't want. I don't want. Ma'am, you take now. Ma'am, six are there. 3 you can take. 3 Sukriti ma'am. Shival sir का भी है क्या? हैं? हैं? एक दो ही है मैम. दो मैम. ये नहीं है मैम. लेकिन काली है. वो किसके लिए? एक्स्ट्रा नहीं. हाँ. ये किसके लिए? सबको ये सबको दिया. I think somebody has not taken it. It is not this one. Because this one. Stall is there. Somebody stall is there. हाँ. इनका यही है ना. मित्तल सर और शिवल श्रीवास्तव सर का है. मितेश सिन्हा. इन दोनों का सामान ये मितेश दिस वन फॉर होम. मितेश सिन्हा. हाँ, मितेश सिन्हा को नहीं दिया. ये यहाँ लिखो.
Good evening. I take this opportunity to formally announce the commencement of the valedictory session. I would now request our Honorable Dean Sir to felicitate the organizing committee. Dr. Swikriti Behra, Chairperson, Professor and HOD, Department Physiology. Dr. Swikriti Behra, Chairperson, Professor and HOD, Department Physiology. Dr. Raghavendra Rao K, Co-Person, Professor, Department Physiology. Dr. Vinay A.V., Co-Secretary, Professor, Department Physiology. Dr. Sindhu R., Organizing Secretary, Professor, Department Physiology. Dr. Hirok Chakrabarti, Treasurer and Workshop Coordinator, Associate Professor, Department Physiology. Dr. Santosh Kumar Jha, Hospitality Coordinator, Associate Professor, Department Physiology. Dr. Shilpa N. Bijur, Scientific Session Coordinator, Assistant Professor, Department Physiology. Mr. Sumit Kumar Singh, Logistics Coordinator, Tutor, Department Physiology. Dr. Maheshwar Prasad, Outreach Conveyor, OSD and HOD, Department of Outreach. It's not there. Dr. Akash Kumar Verma, Tutor, Department of Physiology.
Dr. Ankita Chaudhary, Tutor, Department of Physiology. Dr. Sweetie, Tutor, Department of Physiology.
Dr. Shubham Kumar Devakar, Tutor, Department Physiology. Dr. Megha Thakur, Tutor, Department Physiology. Dr. Navneet Anand, Tutor, Department Physiology. Dr. Sinha Pranay, Tutor, Department Physiology. Dr. Tushar Anand, Tutor, Department Physiology.
We would now like to request respected Director Sir, Dr. Rajiva Dwivedi, to please come up and give away the prizes to all the volunteers, please. All the volunteers, please come up. Names, volunteers का नाम. हाँ हाँ, that will be. Arun Shekhar Anshumali, Anjanesh, Aditi Singh, Aditi Dubey, Anjali, Gaurav, Harpreet Kaur, Himanshu Yadav, Himanshu Bhatt, Navya, Piyush Mohanty, Priyanshu Vijay Minj, Siddharth Kumar, Priyanka, Vidyasagar.
Okay.
We would now like to begin with the prize distribution ceremony for the Neuroquest. I'd like to request Dr. Ashok Jaryal sir to please come up and distribute the prizes.
Students, the first prize goes to Team Green. Almost. Oh, incredible performance of the team. Full, almost full. Almost full.
You have more girl participants in top than the boys.
sir. Second prize goes to Orange team. Sir, one more. The third, there is a tie for the third one. Oh. Blue and pink. Almost. A few, some 3-4 minus. Almost 3-4 less. And the fourth one can join also, because they are all almost neck to neck. That is the yellow team. All of you, please come. It's also a neck to neck competition. All of them have fared very well. Congratulations to all. It was a very commendable performance.
Thank you, sir. Now I request Dr. Svikriti Behera, Professor and HOD Department of Physiology, to kindly hand over a token of appreciation and memento to our respected Dean, Dr. Harish Chandra Bandhu, sir. Sir, please. I also request ma'am to stay and kindly hand over the memento to Dr. Rajiva Dwivedi, Director, sir, as a token of appreciation. Sir, please. I also request Madam to hand over a token of appreciation to Dr. Samir Uli, who was an advisor for us. Sir, kindly, please. We also had Dr. G. Pradeep Kumar as advisor, along with Dr. Sunita Hota. Madam is not there. Thank you, ma'am.
I now invite Dr. Svikriti Behera, Professor and Head, Department of Physiology, to give the vote of thanks.
Good evening to one and all present here. So we have come to the end of this program, and it's my proud privilege as the chairperson of today's National CME Workshop on Diabetic Neuropathy, Autonomic Function Test as key to early diagnosis, to deliver the vote of thanks. I must warn you, it might be a little long. Kindly bear with me. At the outset, I extend my heartfelt gratitude to the management of Manipal Tata Medical College, MTMC Jamshedpur, and our esteemed patrons, Dr. Harish Chandra Bandhu, in charge Dean, advisor, Dr. G. Pradeep Kumar, Dr. Rajiva Dwivedi, Director, for their constant guidance, encouragement, and unstinting support. I would also like to express my sincere thanks to the member of our advisory committee, Dr. Sunita Tripathi, Professor, Department of Biochemistry, for her constant support, advices, and she checked also upon us that how you are doing. Thank you very much, ma'am. Dr. Vijay Kautilya, Associate Dean, Paraclinical, Dr. Sameer Uli, Associate Dean, Clinical, for always being there as a support. Hamesha bola, yes, we will be there. A special, very special note of gratitude to our distinguished speakers and facilitators, the dynamic Dr. Ashok Jarial sir, for his enlightening keynote address and for graciously sharing his valuable time with us. It was amazing, sir. Thank you very much. Dr. Rajesh Kumar Thakur for his thought-provoking session and enriching us with your clinical expertise. Thank you very much, sir, for sparing your valuable time. Dr. Madhumita Sen for her warm support and insightful talk. She was so gentle every time I called. She appreciated every single request that I made for her. Dr. Mitesh Sinha for sharing his depth of knowledge and experience, which added immense value to the event. Sir, I should not hide this thing. Not only he did the workshop, he went and repaired our nerve conduction also and told what our mistakes was. Sir, this is exceptional. Thank you very much. Dr. Shival Srivastava for his infectious enthusiasm and inspiring presence. Sir, all the way, whenever I messaged him, immediately he told back, he advised, why don't you put it in this website, why don't you do this, I should bring handouts. Thank you very much, sir. Not only you gave this talk, you also taught us how to walk this way. Thank you very much. Now, as the saying goes, if you want to go fast, walk alone. If you want to go far, walk together. This journey has been one of teamwork, collaboration, and shared commitment. My heartfelt appreciation goes to Dr. Sindhu R., our organizing secretary, for being the wonder woman that you truly are. Dr. Hirok Chakravarti, treasurer and workshop coordinator, for his unwavering dedication and meticulous planning. You have proved what you are. Special thanks, Dr. Vinay AV, co-secretary, for your constant support. Dr. Santosh Kumar Jha, food and beverages coordinator, who doesn't know how to say no. Jo bhi bola hai, to the T hua hai. Dr. Shilpa and Bijur, scientific session coordinator, for her meticulous and detailed planning. She will scold me also if I deviate, so I left it to her. If I ask her, kaise hoga, bola tha na, madam. Well done, Shilpa, thank you. Mr. Sumit Kumar, logistic coordinator, who had eaten more sweets than anyone else in the department throughout this period because so much he had to do and run around. Thank you. Dr. Maheshwar Prasad, outreach convener, he was there throughout the journey from credit point, for credit points and also actual real outreach. He connected to people, to the tribal people who will bring their things here. He was truly involved in the project. Thank you, sir, though you are not here. He called today also to ask, is it everything okay? You need my help. I have missed out one person. I was told not to take his name. Not told, I was warned. Do not thank me. It is from the department. Dr. Raghavendra Rao K., our co-chairperson, from conceiving the CME idea to navigating every challenge, managing every emotion. हर दिन जाके एक बार रोती थी और एक बार सबको परेशान करती थी. And not me. Every team member is always ranting in front of him. Some may be talking about me also. So I stayed outside till the left and I went and talked about them also. And supporting every single team member, taking the brunt of us all. Sir, you have truly been the backbone of this event. Thank you very much. We are deeply grateful for your leadership and patience. That only you can do. A warm appreciation to our enthusiastic tutors who lit up the workshop with their energy and dedication. The ever-energetic Dr. Akash Kumar Verma, trustworthy Dr. Shubham Kumar Divakar, sincerest Dr. Navneet Anand, our beauty with brains, Dr. Sweetie, Dr. Megha, Dr. Ankita, who have delivered as told. The energetic and ever ready Dr. Tushar Anand and Dr. Sinha Pranay. They also joked about us, I have noticed. Sincere thanks, Sadaf, Priyanka, you have been truly amazing ladies. Saurav, thank you for your constant behind the scenes support. Without you, this could have not been possible. Thank you. Gratitude to our ever reliable IT team, Mahesh ji, Lakshman, Bharat, for their prompt support. I might have missed out names. Please bear with me. Mihir ji and Ankur ji, thank you for going above and beyond. हमारे एक प्रोग्राम था रोज 7 बजे तक मैं उन्हें कॉल करती थी. So thank you for working even beyond working hours. Dr. Sachin Patil, thank you for your multimedia support. A special word of thanks to finance team, Nilima ji, Akash, Sandeep ji, Saubhagya ji and his purchase team, admin team, Kshitij ji, Arnav, our travel desk, जिन्होंने कॉल करके और हमने उनको कॉल करके बहुत परेशान किया, दीपक जी and housekeeping staff, without you they have gone, not possible. And last but not the least, all our participants, attendees and supporters, thank you for your presence, enthusiasm and active engagement. Crossword puzzle आप लोगों ने बहुत दिमाग लगा के किया. Thank you very much for being always present. Our volunteers, those who have risen to the occasion and did everything that we're told to do. Well done, volunteers. Thank you very much. Chocolate baki raha, I'll give it to you. Please excuse me today. Few names, if I don't take, it will be again wrong. Thank you to Sulekha madam, Kavita madam, जो last moment में हमें wise words दिए. Thank you to Dubey ji, जिसके पास मैं घंटों बैठी हूँ. And I have irritated him for lot of things, sent lot of mails to him. Thank you very much. With this, let us carry forward the spirit of learning, collaboration, excellence in our shared mission of better healthcare outcomes. While we go forward, let's not forget our sponsors, Biponi, JP, and our vendors who had brought the instruments right in time, AD instrument and RMS, due to which we had a wonderful workshop session. Thank you very much. With this, I end my vote of thanks. Thank you for being present here. It was truly an amazing experience. Now may I request everyone to please rise for the national anthem. Thank you very much. Janagana mana dinayak jaya he Bharat bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkal Vanga Vindhya Himachal Yamuna Ganga Uchala Jala Vitaranga Tava Shubha Name Jage Tava Shubha Shisha Mange Gahe Tava Jaya Gatha Janagana Mangal Dayak Jaya He Bharat Bhagya Vidhata Jaya He Jaya He Jaya He Jaya 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 He. I request everyone to please can we join here for group photo. UG को जाने बोल दीजिए. UG स्टूडेंट्स को जाने बोल.